Good evening, participants and delegates. Thank you for joining Shield Connect. And today we are going with the mixed bag webinar sponsored by Ranchi Obstetric and Gynecology Society. So let me introduce our convener for today's, Dr. Archana Pathak. Ma'am is Medical Director in MD LM Hospital and Research Center from Ranchi. And ma'am is recently IT Secretary of Ranchi Obstetric and Gynecology Society. And let me also introduce our second convener, Dr. Supriya Jaiswal. Ma'am is currently Secretary of Patna Obstetric and Gynecological Society. And right now, ma'am is Chief Consultant of SM Hospital in Patna. So I welcome you both, the convener, and I will hand over the session to Dr. Supriya Jaiswal.
A very good evening. Thank you, Mr. Nishant. A very good evening to all of you present here. I bring greetings from Team Patna OBGY Society along with this whole mixed bag conference. Today we are all assembled here. So this is a conference, actually mixed bag means we are talking on a different subject and from different places, all from their homes. So it is basically a learning process all of us are here for. So we are very happy to have our chief guest, Dr. P.K. Shah sir, and as guest of honors, Dr. J.M. Kannan ma'am, Dr. Ramani Devi madam, Dr. Sampath Kumari madam, and all the dignitaries who are here. So to begin with, may I invoke the blessings of Almighty, and let us have the lighting of the lamp.
Kurutvam kalyanam Arogyam dhana sampada Shubham kurutvam kalyanam Arogyam dhana sampada Shatru buddhi vinashaya Deepajyotir namostute Deepajyotir namostute Shubham kurutvam kalyanam Arogyam dhana sampada Shubham kurutvam kalyanam Arogyam.
Thank you. May I have the CV of, thank you. So Dr. Suman, it is my pleasure to introduce Dr. Suman Sinha, who is the Senior Consultant OBGY at IVF Infertility Center, Moradabadi, Ranchi. She is ex-Chief of Medical Services of an HOD OBGYN at CCL Hospital, Ranchi. He is on Coordinator Medical Disorders in Pregnancy Committee, FOXY 2019-22, and at present she is President Ranchi OBGYN Society. She is also Convener of Public Awareness Committee, FOXY, Secretary Ranchi OBGYN Society, and she has held many positions in many other societies. So with this, I would like to introduce, welcome Dr. Suman Sinha, and Suman, you kindly introduce our chief guest, Dr. P.K. Shah sir.
Thank you, Supriya, for your very warm introduction. A very warm and cherished evening to all the esteemed faculties and delegates. I, Dr. Suman Sinha, on behalf of Ranchi Obstetric and Gynec Society, take the august honor to welcome our chief guest, very honorable and very respectable, an iconic figure, past President FOXY, Dr. P.K. Shah sir. Next, I take the privilege to welcome our revered guests of honor, very well known to all of us, Dr. J.M. Kannan madam, who is our past Vice President FOXY, Dr. Ramani Devi madam, who is also past Vice President FOXY, and Dr. Sampath Kumari madam, who is Vice President-elect FOXY. I welcome our very accomplished guest speakers, Dr. J.M. Kannan madam, Dr. Chinmaya Ratha madam, who is Chairperson Fetal Medicine Committee of FOXY, Dr. Ajay Mane sir, who is Chairperson AMOX Website Committee. I welcome our very dedicated chairpersons, Dr. Vinita Singh, who is President Patna OBGYN Society, Dr. Chitra TB, who is President Coimbatore Society, Dr. Purnima, who is Secretary Erode Society, Dr. Vijay Lakshmi Madam, who is Treasurer, Federation of Tamil Nadu Society, Dr. Shanti Rani, President, Tennis Society, Dr. Jyoti Sundaram, President, Madurai Society, Dr. Selva Priya, Secretary, Nagar Coil Society. I also welcome President Chennai, Dr. Premlata Madam, who has joined on my request. Thank you, Madam, for joining. I welcome another very dedicated I welcome the moderator of our panel, Dr. Kiran Trivedi, myself, and Dr. Supriya Jaiswal as expert. I welcome all the very experienced panelists, Dr. J. Amla Devi, Dr. B. Kalpana, Dr. Hemlata, Dr. Uday Arun, Dr. Benita Rukmani, Dr. Sasi Rekha, Dr. Saroja Veluswamy, Dr. Kavita Barnwal, and Dr. Purba. I welcome Dr. Archana Pathak, who is the Master of Ceremony. I welcome our educational and technical partner from Shield Connect for supporting us. And now I have been given the pleasant task to introduce our chief guest, Dr. P.K. Shah sir, who does not need any introduction. He is a legendary figure in Foxy, a true academician, teacher of teachers, guide and philosopher, mentor to an inspiration to many of Foxians. We are fortunate to have you, sir, here today. The CV displayed here is very small compared to what he is. Regarding his academic achievements, sir was professor and unit head at the Department of Obstetrics and Gynae at Seth GS Medical College and KEM Hospital at Parel, Mumbai between 2008 to 2016. He has been past dean of Indian College of Medical Ultrasound between 2015 to 2016. He has been past president of Indian Association of Gynecological Endoscopists, IAGE. He has been also past president of Foxy, we all know that. He has been past president of Indian Federation of Ultrasound in Medicine and Biology, past president of Mumbai Obstetric and Gynec Society. He was past president of Association of Full-Time Teachers at KEM Hospital. Past
enough.
Sir,
Enough.
Sorry, just a minute, sir. Just 1 minute. Fellow at WellStar International USA, Foxy representative to FOM. He has been past editor of OB-GYN Journal today, co-editor of Journal of IFUMB, member of State Motherhood Committee FIGO between 2013 to 2018, member of USG Committee about 2013 to 2017, and chairman of Imaging Science Committee for 2017-2019. And one thing more I want to add, sir has come to Ranchi, to my hospital, and has demonstrated workshop on ultrasound. And he had taught us things so simply that we all followed, and we are following the things which you have taught us, sir. So, sir, we would like to take your blessings.
Thank you.
Before sir starts, shall I add one thing to his biodata, which is very important?
Yes, please.
Yeah, with the permission of Shah sir. Okay, sir. Yeah, we are enjoying the privilege of doing the sonography very freely with your degree only. That has been made possible due to P.K. Shah sir only. He was after that, all the degree holder, diploma holder of gynecology and obstetrics must be allowed to perform, and that is only done by P.K. Shah sir. He is boss in sonography. Already sonography has been started by him. Sir, we go to you.
I think sir
that is
went to
the only thing I
all
was.
over India to teach us. All over India he visited to.
No, but the provision is made by him only.
Okay, enough. Yeah. Dr. Suman, thank you. Dr. Ajay, thank you. At the outset, let me thank Dr. Suman Sinha for giving me this opportunity to be with you all and making me a part of this webinar. It's a great pleasure to be sharing this platform with three stalwarts from South, Dr. Jayam Kanan, Dr. Ramani Devi, and Dr. Sampath Kumari. I also thank the rest of the organizers of this today's webinar on mixed bag, and that includes Dr. Kiran Trivedi also. So nice to see that there are 3 talks, one on management of PIH, second one on discordant twin, and third one on medical legal aspects of keeping documents in obstetrics. They are going to be delivered by none other than Dr. Jayam Kanan, my favorite Chinmay Ratha, and Dr. Ajay Mane. And then a nice panel discussion is going to follow on hypertensive disorders of pregnancy, which is again going to be moderated by Dr. Suman and Dr. Kiran. There are so many stalwarts, I cannot take everybody's name, but it is so important that I have seen the change in webinars. The topics chosen nowadays are really important from practice point of view, day-to-day practice of an obstetrician. And that is what makes nowadays webinars very important. Let us understand we are all from major cities, many of us. It is easy for us to travel from one place to the other for physical conferences. But there are so many gynecologists who are practicing in small parts, small towns, villages of our country. And they're the only ones, the only gynecologists, either she or he, and cannot leave the practice to come and attend the conferences. For them, these webinars are a boon. They get complete knowledge within few hours on different subjects. And this is something great that has happened in last 2 years. That is the advantage of COVID. Let me put it that way. Though we all know nobody would like to have COVID again in our country or in the world again. So it is so nice to see that there are people from north and people from south. The balancing act is being done by Dr. Suman Sinha. Everybody is involved in today's webinar. And all those who are fighting election in Foxy, I wish them all the very best from the inner core of my heart.
Thank you.
Keep working hard. Don't expect anything. You have to be seen by people. Not only seen, people have to see you working for Foxy. And that will bring about the results that you expect. So all the best to all of you. And thank you very much, Dr. Suman, Dr. Kiran, and the whole Branch OBGYN Society for giving me this opportunity. All the very best for this webinar. Thank you very much.
Our pleasure to have you here, sir.
Thank you.
Thank you, sir. Thank you for
Thank you,
your
sir.
pulse
Thank you,
of-
your blessing.
Dr. Archana?
Yes.
Yeah, sorry, I didn't take your name, Supriya. I think you are an expert in the panel. I'm extremely sorry for missing
No,
out your name.
Thank you, sir. Thank
And
you.
the other master of ceremony, all youngsters are there. Dr. Archana Pathak also. So it's
Thank
nice to see, except for 2 gentlemen, myself and Dr. Ajay. I think all rest of the ladies are going to manage the show today evening. Thank you.
Thank you so much, sir, for your blessings. And it is our privilege to have you. Now I request Dr. Supriya Jaiswal, Madam, who is very active, Secretary of Patna Ops and Gynae Society. And Madam is Zone Coordinator, Adolescent Health Committee Foxy, and contesting for the Chairperson, Adolescent Health Committee Foxy. My best wishes to you, Madam. And it gives me immense pleasure to request Dr. Supriya Jaiswal, Madam, to kindly introduce our guest of honor, Dr. Jayam Kanam, Madam, past Vice President Foxy, and Dr. Ramni Devi, Madam, past Vice President Foxy, for their blessings.
Thank you, Dr. Kiran, for your lovely words. Dr. Archana, sorry. Thank you very much. And thank you for your good wishes. It's a real proud privilege for me to introduce Madam, none other than Dr. Jayam Kannan, Madam. Madam, Madam needs no introduction. She has, thank you, Madam, for being the chief, for the guest of honor today's program, Madam, for this mixed bag. So, Madam is Foxy Adolescent Health Committee 2013 to 15. She's been got the Best Committee Awardee at Emeritus Professor, Tamil Nadu MGR Medical University. She's the Managing Trustee, Rakshaki Group of Institutions. She's the Director of GFC Fertility Center, Trichy and Chennai, Vice President Foxy 2018. Madam had been President, Free Legal and Center for Women, Trichy since 1992, then member of PMNCH WHO since 2008 and certificate course in reproductive medicine, Foxy, since 2012. So Madam has got many achievements. She's the president of India Medal for Outstanding Performance in MBBS. Then she has got many awards, honors, state first in MBBS, university test, first in MD, best paper award 4 times, best book in medicine award 2 times from Government of Tamil Nadu, Duru Shah SN Pandit Award, Foxy Community Work, Best Committee Chairperson. Then she has got many lifetime awards received from IMA, Tamil Nadu MGR Medical University, Trichy Women Association, Academy of Clinical Embryologist, Best Society President Award in 2013. And she has got many publications to her credit in regional languages 5 and English 1. So, and she has also got the RCOG Award, Distinguished Service Medal 2018, first Indian to receive. So it is an honor and privilege to have you with us on this dais, Madam. With these words, I really seek your blessing. We bless our conference.
Very nice to see many of you people who are to be elected to the Foxy highest posts, along with the people who have already been elected and worked like me and Ramani Devi and Sampath Kumari, eagerly waiting to work. The galaxy of the people, along with P.K. Shah, who has been the uncrowned king of Foxy since, I'll say 1983, as I know. It is now nearly 40 years I have known him, and the way we have moved with the ultrasound missions at Mumbai in his place is something commendable. And he is one of the pioneers who has invented many of the angles in which the ultrasound machine could be handled to see the kidney, liver, leave alone uterus. So such a persons we are working with, and I'm really happy to see the young elite batch of Foxians like Suman, Supriya, Jai, the Singh TV Chitra, Kiran, and others who are trying to come up, along with people like Chinmayi, who is, even though already elected, is a young bud in the Foxy panel. So I would expect the young bud Chinmayi to guide them appropriately on the present state of affairs of how to come up in Foxy. Because for me, Ramani and Sampath Kumari, we finished a few years ago. Chinmayi is a budding one. So she can guide you, Chitra and others, take her advices so that you will know how to proceed up. Ajay Mani is my friend, and we used to be 4 people along with Ajay, Vinay Kelkar and Pardeshi from Aurangabad. We used to be the backbenchers in 2007-8 in Managing Committee Foxy, and we slowly tried to move on. I moved first, Pardeshi moved next, and now Ajay is moving, to be followed by Vinay Kelkar. I hope so. So with this, I wish all the best for all the upcoming people and to the members of the Ranchi and Patna and other northeastern parts of this country to grow more with their knowledge and support the women in distress and help to reduce the maternal deaths in our country. Thank you very much.
Thank you, Madam.
Thank you, Madam. Thank you.
So thank you for your wonderful words, and everybody will be enriched by today's program, Madam. Thank you. Thank you very much. So may I have the CV of Madam Ramani Devi? So thank you, madam, for accepting to be the guest of honor today. Dr. Ramani Devi, madam, she has been the managing director of Ramakrishna Medical Center, Janani Fertility Center, immediate past Vice President Foxy. Madam has got many achievements to her credit. Dr. APJ Abdul Kalam Award, recipient of Dr. Navmani Bose and Dr. So many awards, that D.K. Datta's Award, Mehru Dara Hansotia Award, presented papers in national and international conferences of FIGO. Then Madam had authored so many books. She is the investigator of poised trial published in a Lancet, editor of Foxy GCPR on endometriosis, awarded SN Pandit and Shailaja Pandit Award, ICOG Governing Council member, and many things to her credit. Madam is also National Vice President Foxy in 2020, as I said, peer reviewer member of JOGI ARCOG, JAMMR, international editor board member of Bangladesh Journal of Fertility Society. Then she has been the patron of Tamil Nadu Federation of Obstetrician and Gynecologists, editor of Endometriosis Update published in the Society of India, then awarded Pride of Foxy 2022. Recently, UNICEF certified master trainer for violence against women. That is a burning topic these days. So with these words, madam, we cannot add on to all of your credits. Madam, you have too many. And with these words, I really seek your blessings. Kindly give us your blessings, madam.
Thank you, Dr. Supriya, for your nice words. First, respected Dr. P.K. Shah, chief guest for today's program, and guest of honor, Dr. Jayam Kannan, Dr. Sampath Kumari, and speakers, Dr. Chinmayi, Dr. Ajay, and Suman Sinha, President of Ranchi Society, Kiran Trivedi, Secretary of Ranchi Society, and all the faculty members for today. And more than that, all the members who are going to who are going to participate in the election of Foxy. I wish them all the best. And I think this sort of webinars are really a very good one, because we can get to know each other. See, it is not easy for you people from Ranchi to come over to down south and visit all the societies. But just by the mere participation in this webinars, we are able to meet each other. And Sir P.K. Shah, sir, my pranams to you. I don't know whether you remember, it was for the first time I was introduced to you by Dr. Jayam Kannan when I wanted to contest for the chair for endometriosis committee, and you had blessed me enough that time. Thank you, sir. And advanced wishes for International Women's Day. And the theme is gender equality today for a sustainable tomorrow. So I wish all the women of the universe to have a celebrate this happy International Women's Day celebration. And I think our unity will try to be a sort of strength for us, for our own self. And with that, we can achieve many more things. So with these words, I wish this webinar, a mixed webinar, which has got very important topics like high pressure in during high HTP in pregnancy, that is going to be delivered by none other than Dr. Jayam Kannan, and Chinmayi Radha regarding congenital anomalies in twin pregnancies, because we often get this sort of case scenarios, and at times we do not know what we have to do. Then Dr. Ajay Mane, again, who's going to talk on documentation. That is very, very essential in our practice to safeguard ourselves from the litigation, and the panel discussion. And the moderators and the panelists, I wish this program a grand success. And advanced wishes to all those doctors who are going to contest for the post of Vice President or Chairperson, etc. Thank you.
Thank you, madam. Thank you very much for all your pearls of wisdom and for the good wishes for all of us. Thank you very much. Now we begin with the scientific session. And for
Madam, Sampath, madam.
Sampath Kumari, madam.
Oh, sorry, madam. So I hand over to Dr. Archana.
Thank you so much, ma'am. Now I request.
Sorry, madam.
Now I request Dr. Kiran Trivedi ma'am, who is our dynamic and active secretary of Ranchi Ops and Gynae Society. She is the organizing secretary of FOXY for Yuva Conference 2022. And ma'am is the life member of IMA, FOXY, ISOPARV, IFS, and also a member of PCPNDT State Supervisory Board. And she has been invited as guest speaker in various AICOG and other national conference. I request madam to kindly introduce our Dr. Sampath Kumari madam, who is our Vice President FOXY elect.
Thank you, Archana, for a kind introduction. Very good evening and warm welcome to all of you in this galaxy of stalwarts of Ops and Gynae. Please, CV of ma'am. So today I am feeling very pleased to get this opportunity to introduce our respected guest of honor, Professor Dr. S. Sampath Kumari ma'am. She is FOXY Vice President-elect 2022, Founder Secretary of Tamil Nadu Ops and Gynae Society. She is National Correspondent Editor of Jogi 2021 to 24. She is Senate Member of Tamil Nadu Dr. MGR University 2021 to 24. She is Chairperson FOXY Adolescent Health Committee 2016 to 18. Deputy Director of and Professor of Ops and Gynae. She is retired professor from the Institute of Ops and Gynae, Madras Medical College. And she is President Board of Studies Ops Gynae, Tamil Nadu Dr. MGR Medical University 2015 to 19. She is member Board of Studies Obstetric and Gynecology, Meenakshi Medical University, and from 2015 to 20, she was ICOG Governing Council member. So we want a few words of blessings from Madam, and we are blessed to get her good wishes for our today's webinar. Please, Madam.
Thank you, Dr. Kiran. First of all, good evening and thanks to all the delegates and the faculties. And I thank Dr. Supriya and Dr. Suman and Dr. Ajay for involving me. That too in the important seminar with the great personalities like Dr. P.K. Shah sir and my mentors, Dr. J.M. Kannan and Dr. Ramani Devi madam. See, this is a good webinar with important topics of hypertensive disorder in pregnancy, that too delivered by Dr. J.M. madam. We have done a lot of HMS programs on PAH and PPH with madam through Tamil Nadu, not only in Tamil Nadu, in Northeast, everywhere we have done. It's really a mixed bag webinar with the speakers of North, South, East, and the topics also very with the hypertensive disorder, twins, and of all this we have nowadays the medical legal issues by Dr. Ajay Mane. Once again, as everyone told, all the wishes to Dr. Supriya, Dr. Suman, Dr. TV Chitra, and Dr. Ajay Mane for the incoming election, and I wish all the success and a happy International Women's Day with the support of men. We should also have a good support from them. Then only we can celebrate the International Women's Day with full success. Thank you. Thank you.
Thank you, madam.
Thank you, ma'am. Thank you.
Madam, basically, I don't believe in one day, that's Women's Day. 365 days are of Women's Day. That is the truth, basically. Everything is created by women, handled by women, and carried forward by women. So it is a 365-day Women's Day. Completely.
But to honor one day, sir.
Men have to support, sir.
Thank
Men
you.
have to support women. Men have to support women.
See, male have no power like women. The God, they have created any power, any Shakti. When 3-4 God come together and created one Shakti, that is only Devi. That is not a God anytime. All Devis were there. So one woman is equal to at least 4 to 5 men. So all 365 days are belong to women.
Only one point. P.K. Shah sir, do you remember or not? I don't know. In Kanyakumari, J.M. Kannan madam organized one conference. Madam wrote Tamil book on pregnancy, adolescent, everything. You gave the Tamil books to me. What I am going to do this Tamil books, and I have that book still. 4 books, I think, you gave in Kanyakumari, sir. Thank you.
Thank you, madam. Now over to Dr. Archana.
Thank you, Sampath Madam, for your inspiring words and your blessings. And now we begin our academic session on topic medical termination of PIH.
Medical treatment.
Medical treatment of PIH, sorry. And I invite our chairperson for the first session.
Dr. Archana, Dr. Jayam is going to kill you.
Sorry, our first chairperson is Dr. Chitra TV, and she is the professor and unit chief of obstetric and gynecology, PSC Institute of Medical Science, Coimbatore, Tamil Nadu. And she is the president of COVI Obs and Gynae Society, scientific committee member of Viva Foxy 2019, and a member of IUGA and ISOUG. She has a special interest in urogynecology and high-risk pregnancy. With her to chair the session, we have Dr. Vinita Madam. She is the Associate Professor, Obs and Gynae, NMCH Patna, Consultant Care Hospital and IVF Center. At present, she is the President, Patna Obs and Gynae Society, and she is the Organizing Secretary, NICON in 2019, invited faculty in workshop PIGO, and she has many awards like MG Mishra Award in 2004 and George Moni Award in 2012. I request Dr. Vinita Singh Madam to kindly introduce our speaker.
I think I am already introduced, isn't it? Yes.
Vinita.
I think we'll move on to the topic.
At the very outset, I would like to thank Dr. Suman for giving me. So, ma'am, let me take pleasure to say, okay. So over to Jayam Kalan, madam. She is going to speak on how to manage pregnancy-induced hypertension. Over to madam.
Okay. Can I share my screen?
Yes, ma'am.
Is my screen visible?
No, ma'am.
No, ma'am.
No, not yet.
Not yet, ma'am.
So probably you have to allow me to share screen.
In the meantime, when madam is just getting her.
Yes. Now I am allowed.
Okay, ma'am.
Now I am allowed. Am I right? Yeah. Now I am allowed. Okay. Oh, sorry. I went to the last and then came. Right. Medical management of pregnancy-induced hypertension?
No, ma'am.
Yes, we can see.
We can see, no?
We can see, ma'am. We can see.
Madam.
Pardon?
We can see.
Madam, very report.
Yeah. So, as Sampath Kumar has said, I've been working on it for more than 3 decades because my practice goes to nearly 5 decades. And the way I have seen patients dying and myself not knowing what to do in these hypertensive disorders and pregnancy, I took it up. Now I am showing you 2 case scenarios. Please go through it so that my topic is easy for you. A primary gravid is having the follow-up from 8 weeks of pregnancy. She had 96/70 blood pressure, and yesterday she came to me with 35 weeks of pregnancy with 130/84 and headache. So my junior obstetrician asked her to come today at 10 a.m. for a recheck. She landed at 6 a.m. unconscious with a history of having thrown a fit at home. Could this have been prevented in the last 24 hours? That is the first question. A patient who has been a regular booked case. Now the case 2 is a 25-year-old again. At 28 weeks, she complains of headache and abdominal pain, and she has been having it in the last 4 or 5 days. She was always having a regular checkup and she was never told that she had blood pressure. Now today her blood pressure is 175/95, and on examination she has got right upper pain, urine is 3+, Immediately admitted in the ward, Maxelf and other labetalol oral started. 5 hours later, she threw a fit. Again, in this case, could we have avoided? In both these cases, the management that could have been given to her is the question of burning topic of today. So recording the blood pressure, we all know well how to record it. 89/56 is normally recorded in many people. 100/66 is also normally recorded. And this patient continues to show 100/70, 120/80, which is also considered normal. And a couple of days ago, she comes with 147/93 recorded in the standard way, both arms, sitting, everything. And this has been as per the international guidelines. In this patient, at the first incidence of 140/90, should we have started the drug, or we should have waited for the regular recheck for after 4 hours or 6 hours and then start the drug becomes a burning question. Because her earlier blood pressure has been 86/56, 100/66, 100/70, 120/80, and today it is 147/93 in both arms, almost same. So in this case, the international rule of checking, a rule of 3, all these things, does this apply on this visit itself, becomes a question in which the obstetricians are put into great distress. You have not followed the protocol. Somebody will come and say, you started the drug very early and you landed in complications. All those things will be told to you. Now, coming to this, the standard is 140/90 after 20 weeks. Proteinuria, not significant. But outside the office, 2021, India International Society of Hypertensive Disorders and Pregnancy has come out with 135/85, which is also pathological, which should also be treated with the drugs. This is Lara Maggie, last year, 2021. Any of you is interested? I request Chinmayi to give the AACC RCOG lecture by Lara Maggie last about 4 months ago. She should be having the details. I also have, but she as an AACOG person, RCOG person will be having it in a better way. All these things, all these definitions and all these things are known to everyone. And patient who has a blood pressure of 140/90 might have been even been treated and she would have had this blood pressure. That means this also requires to be looked at. And if you think of blood pressure with preeclampsia, note down 5 points. Blood pressure, proteinuria, edema, one of the maternal symptoms and signs, and fetal growth restriction. What are the symptoms and signs? Or the 5: unusual vomiting, pain, abdomen, photophobia. Now in the present days, I put it in red letters, unable to see the cell phone numbers properly. I remember Sampath Kumari in every meeting of our HMS insisting on all the 5. And now, at that time, that was about 15 years ago. Now you see, I'm not able to see the cell phone number. That should warn you about the fact that she is going in for visual discomfort. All these factors have been scored by Bayesian score and Gestosis score from low, middle, and high risk. Bayesian score should be very well known to RCOG people, and Gestosis score should be known very well to the people from FOGSI and who are practicing in India. This Bayesian score is a score which has been used by the Kerala group in the last 10 years of why mothers die, the confidential data collection. And recently it is being also looked at in the Asian perspective and is supposed to have come out by this year. 2019, the work was over, but still it has not come due to COVID. Probably this year, we should be getting the Bayesian risk algorithm with all the points, which almost is equal to what is Gestosis, but it is little internationalized. Coming to the Gestosis score of what has been put up by Gorak in many meetings, for every 1 point and 3 points, 2 points, he has given the details. You have it as an app and you can download it from the Gestosis app also. And any point above 3 means at risk for preeclampsia. If you don't even have blood pressure, you have a normal blood pressure, but still the patient has a multiple pregnancy, as Chinmay is going to talk about today, that means she has a score which has been looked into. If she is a case of polycystic ovary, automatically she gets 1 point plus. Totally 3 points and above is a person at risk for eclampsia. So you see them at 8 weeks and mark them as at risk for eclampsia. What you have to do is a question which we are going to talk. There is also a separate entity. The second case which I have shown, a case in which her blood pressure has been recorded normally, and with 5 days of unusual symptoms, she lands up in the hospital with 175/95 and throws a fit within a couple of hours, is a classical atypical preeclampsia, which does not follow any rules or lines, no code of contact, and it is very rapid in progression, and timely diagnosis becomes very, very critical. Organ involvements may even start even before you make the diagnosis of atypical preeclampsia. This is one Dr. Sibai has made a lot of work on this, and you can go through that also. So now we are more focused on hypertension, gestational hypertension, preeclampsia, and eclampsia, but not to forget all the other symptoms like help also in these cases. If we have somebody is speaking.
No, ma'am, no, ma'am.
Yeah. If you have found out a patient who had a 140/90 at OP one time recorded, her chances of proteinuria and developing classical preeclampsia is 40%, which has been said in the last 15 years and holds good also. All the biomarkers which we are talking about in the present scenario in tertiary hospitals are either say that the placenta is diseased, endothelium is dysfunctional, or already the organs have undergone some changes due to this. Does any of these things give a warning and as at risk? Is not the case, because none of these markers should be present in a normal pregnancy. They should be available only in patients who is a preeclampsia. If supposing this sort of a marker comes, that becomes the more important one. Presently, the markers are scientific evaluation. None of them has come to this record. So now we turn on to the outpatient, where the patient comes, says she has pregnancy and she has come to you with the records and you are checking her up. Her blood pressure is being taken up in the standard procedure. Kindly do not forget our EMONC advises, EMONC and EMOC advises a rise of 30 millimeters of systolic and even 20 millimeters of diastolic. Please put the patient at risk. So now you have got gestosis, blood group, blood pressure, the Bayesian model, and even the EMOC and CMOC, our government institution, which says 90 plus 30, 120 blood pressure. If you have recorded, please treat her as a patient of hypertension in pregnancy after 20 weeks. All these patients should have undergone a first trimester screening test properly and identify at risk for preterm preeclampsia. And biomarker, if you have availability, please do it and triage it. And your biomarkers also, if you are staying in places like Delhi, Mumbai, and Hyderabad, where you can do all these things, and classify the patient at the OPD itself as at risk and start the care. So you have seen her at 8 weeks and you have put her at high risk. What are you going to do? Started as aspirin from 2017, well confirmed with 2021 is aspirin earlier by 12 weeks itself. Because it is the presentation which is defective and it balances the thromboxane A2 and prostate, and adequate uterine placenta blood flow is maintained, and luckily there is no perinatal and maternal complications due to this dose of 75 to 150 milligram of aspirin, and you can give even throughout pregnancy. Just a couple of days before cesarean, if you have planned, you can stop it. Even if you have done it given yesterday and today the patient comes, I have not seen a patient going in for any bleeding problems. So the evidence from the aspirin trial has made it very clear. Please understand, aspirin reduces by 60%. If you have started by 11 to 14 weeks at the earliest, dose has to be 150 milligram, one dose at night, and deliver the patient by 37 weeks, which reduces the preeclampsia. Aspirin did not reduce the term incidence of preeclampsia. That means you have given aspirin and you have taken the patient beyond 37 weeks. At 40th week, she shows any of this atypical preeclampsia. That means it's correct because you have not terminated the pregnancy by 37 weeks. We have the WHO manual, which gives us all about A to Z answers on prevention and treatment of preeclampsia and hypertension, from bed rest, marital life, sleeping posture, all those things. And in this one important measure, this thing that has been given a strong recommendation is use of calcium in low resource settings like India, 1.5 to 2 grams, which is recommended in the prevention of preeclampsia and in all places where there is at risk of patients for developing preeclampsia. So aspirin and calcium are the drugs should have been started at 8 weeks of pregnancy in the outpatient at-risk patients. Now, having given these drugs, you have had patients who are 90 by 60, who has come with 126 by 90 by CMOC, and by 135/90 as per International Society of Hypertension, or by the classical 140/90 you take, you could have to start on a antihypertensive drug along with aspirin and calcium. Before 2011, hydralazine was most studied, but after that it is labetalol, nifedipine, which are taking up the hierarchy. And I'll say all the more of labetalol, as it is very easy to administer. For nifedipine, we make it very clear that we have to give it orally, and drugs not to be used are ACE inhibitors and atenolol group. WHO still maintains a goal of 140/90, but our EMOC and CMOC of Indian scenario maintains basic blood pressure plus 30 blood pressure systolic plus 20 above diastolic. I make it very clear for all of you people. Labetalol, what is the dose? You can start with 100 milligram twice a day and go up to 200 milligram to 400 milligram twice a day, up to a maximum of 2,400 milligrams per day orally. Peak effect is reached by 2 to 4 hours. And if you are given a 100 milligram, it takes 8 hours. If you are given totally 300 milligram, by 12 hours, you will get a very good response of the blood pressure, and adverse effect slightly are seen are the bradycardia and little dizziness. But kindly note, it enhances the fetal lung maturity very well, which can compromise the small problems that you can see. Now coming to nifedipine, no sublingual tablet. It's a calcium channel block. Maximally can be given 10 milligram BD up to 120 milligrams. Adverse effects are very small compared to the dose which is here. And nicardipine is another drug which is also brought, which is little more faster in action than nifedipine, and it is more known to the medical persons. And the follow-up, what you do in these patients, having given and followed up within 24 hours, follow it up every 4th day initially, thereafter shift to every 7th to 10 days. Depending upon her improvement, you can go and repeat proteinuria test as it requires weekly or once in 15 days. And always look for these premonitory symptoms: headache, visual disturbance, reduced movements, and right upper abdominal pain and vomiting. These 5 things you should never forget in these people, and it has to be marked in every case of at-risk patients. And when you have given the drug, she has responded or she has not responded, when to admit her. If she is not able to follow up in the OP, or if she has not achieve the full reduction in the blood pressure, like 160 systolic and 100 diastolic, or even the same persistent 140/90 for the past more than 15 days, probably you'll have to admit and follow it up for 24 hours. At the same time, kindly do not discontinue aspirin and calcium, and think whether you should start a oral drug or parenteral drug, depending upon whether you are seeing the patient case 1 or case 2. In the case 1, we had the patient with a sudden rise in the blood pressure. Had we started it parenterally instead of orally, we could have prevented the eclampsia. That is where we have to use our judgment and experience and give the drugs. Labetalol, once we have started to give IV, start with 20 milligram IV, 10 minutes, repeat 20 milligrams if the blood pressure is high. Again, 40 milligrams if the blood pressure is high, at a maximum of 300 milligrams in 24 hours. If the blood pressure is reduced down, you must switch over to oral also if she settles well. If you are taking nifedipine in the ward, 10 milligram every 30 minutes, a maximum of 120 milligram, and shift to slow release if possible if she settles down also. Now, that means nifedipine, retard group of drugs, at any time do not give sublingual. And if supposing you have seen this patient with any of this headache, visual disturbances or other things, 5 points which we have marked out prior to 34 weeks, also consider max self to these patients, and always induce labor by 37 weeks as I have pointed out. Postpartum period also, patient requires a proper checkup. Long-term sequelae has to be discussed with the patient. If you are seeing before 34 weeks, also give antenatal corticosteroids and initiate a urine monitoring also. Depending on the maternal symptoms, you may deliver the patient and avoid getting HELLP and renal problems also in these patients. And if the role of steroids in preeclampsia, if there is no severe features, it is quite good. And ACOG guideline also very promptly says, even in Indian guidelines of Lakshya, 24 to 34 weeks antenatal corticosteroid is a must. Under control with labetalol, this has to be given to these patients also. So, rushed delivery in a patient with unstable blood pressure is very, very dangerous. Please stabilize her, treat her with anticonvulsants, and transfer her with proper appropriate support, or deliver her appropriately also. Reducing the risk of preeclampsia, aspirin is being time and again said, but many patients aspirin is being not followed up, and 20% excess of preeclampsia in India is still due to the failure of taking aspirin, the dose at least 75 which has been given earlier, 150 now from 2021. So take home message is, record the BP properly. Every day or week monitor this thing, chart with the premonitory symptoms of all the 5 which I have said. Effective screening tool to find out the women at risk. Always supplement aspirin with calcium and correct the anemia, which adds beauty to your work, and vigorously correct the blood pressure. Do not think I am giving 800 milligram per day labetalol is a high dose. You can go up to 2,400 milligram per day oral. If you are in an institution, see that the work is done in your institution as a protocol. Establish good champions who can monitor the blood pressure and avoid preeclampsia situations and eclampsia, and provide convincing evidence that the proposed change will improve the success of the hospital to your institution head, which is very, very important, and distribute the convincing rational evidence both to your higher people hierarchies and to the patients also. So preeclampsia care plan has to be 26 weeks and above, stabilize and terminate. Up to 33 weeks, if supposing 26 weeks and below is termination, 26 weeks to 33 weeks, it is expected management with steroid, with Maxel, with aspirin and calcium as required, and deliver as per indication. About 34 weeks, stabilize the patient, deliver, or if she is uncomplicated preeclampsia, do not wait beyond 37 weeks to deliver her. Be a proud peacock Indian and happy Women's Day to save our mothers dying due to hypertensive disorders in pregnancy. Thank you very much.
Thank you so much, ma'am, for a wonderful talk. Now I request Dr. Vinita, madam, to kindly sum up the topic. Dr. Vinita, madam.
Yeah. There's a message from her. Actually, she was not feeling well, so she had to leave. She is still there, but then she won't be able to.
Can
Yeah.
I do, ma'am?
Yeah.
Chitra ma'am she will conclude.
Yeah. At the outset, let me thank Dr. Suman Singh and Dr. Supriya for having really remembered us. It was so kind of them to having given me this opportunity to be with you all this entire evening. And I must say, this was an excellent talk by Jem Kannan ma'am. Very short and sweet. Madam, I have seen you in Coimbatore. What I remember about PAH is, you very boldly said 1 ampule of magnesium sulfate is equal to 1 gram. That didn't into my head. Because that's so important, we get confused. Is it 20%? Is it 50%? Always a confusion was there. But that day I still remember, whenever I think of magnesium sulfate, I think of Madam only. She put it 4 ampules is equal to 4 grams. So that was there when she was going around, when all the societies will talk about eclampsia. So I still remember that, man. And today the take-home message, like you said, was excellent. It's important that we stress upon, though the BP is 140/90, any BP increase, which was told us earlier on in those days, I think we should pay a lot of attention. Her BP was 90/60 and then it has increased to 130. We cannot ignore it. So that's an important message that all of us should go. We should not go by 140/90, but any BP increase in BP, I think we should really pay a lot of attention. That was one point that all of us should remember. And again, calcium, we tend to give only 500 milligrams of calcium. But there are evidences saying that we have to increase the dose of calcium. That's another important thing that we have to do. And there are a lot of cases which are atypical, which now there is latest classification which says severe, PAH with severe features. So the BP alone could be still normal. But if she has other problems like a headache or her LFT is abnormal, then again she becomes a high risk. So we really have to segregate, because we see patients with only hypertension, not preeclampsia. But still, if she has severe features, we have to look into them very, very carefully. So thank you so much, ma'am, for that excellent and very brief and wonderful presentation. It was real lovely to hear you again. And I will never forget 1 ampule, 1 gram. And thank you, Dr. Sumana and Dr. Supriya, for this opportunity. And for everybody, for their wishes. It just really came from the heart to listen to PK Shah. It was so nice, and all the well-wishers, Jem Kannan ma'am, Ramani madam, and Sampath Kumar madam. I wish you all and hope all the other contestants will really succeed in their endeavors. And thank you so much once again. Thank you all.
Best wishes to you also, madam.
Thank you.
Jay, madam, can I ask one question?
Yes, please.
Madam, a patient of hypertension, and we have started giving her aspirin, and she develops proteinuria. So should we continue with the aspirin or we should stop?
Aspirin has no relation to the proteinuria. Aspirin should be continued. Aspirin should not be stopped because she has got proteinuria. The proteinuria which manifests in a patient who is already on gestational hypertension treatment shows that she is going into renal involvement. That means she is getting one of the features of the preeclampsia going in soon to eclampsia. That means 1+ dipstick in a patient who has never been positive, has been on treatment on labetalol and ifidapine, shows that she is going in for preeclampsia. From gestational hypertension, now she moves on to gestational hypertension plus preeclampsia, wherein aspirin is the drug of choice. Except in eclampsia, where we are going to terminate the pregnancy, where we don't bother about aspirin or calcium. In all, because in the preeclampsia patient, she may settle down and we may take her another 1 week or 2 weeks to deliver her. In that case, that is why I said we forget to give aspirin and we make the disease progress very badly in 19 to 20% of the cases by stopping the aspirin.
Okay. Thank you, madam. Thank you.
Thank you, ma'am. Now, moving on to the next session, that is on management of discordant anomalies in twin pregnancy. For this, I would like to introduce our chairperson, Dr. S. Vijayalakshmi Madam. Madam is Associate Professor of Ops and Gynae, ACS Medical College and Hospital, and formerly she was the Associate Professor of Ops and Gynae at Karpaga Vinayaga Medical College and Meenakshi Medical College, and the Treasurer TNFOG, Executive Committee Member of OGSSI, and her field of interest is high-risk obstetrics, adolescent gynecology, and infertility. With her to chair the session, we have Dr. Purnima Madam. She is proficient in performing all gynecology and obstetric surgeries, experienced in conducting all high-risk labor, experienced in infertility workup, and she is a certified ultrasonologist, infertility specialist. And I would request Dr. Purnima Madam to kindly introduce our speaker, Dr. Chinmaya Ratha Madam.
A very good evening to one and all. I take extreme privilege in introducing Dr. Chinmayi Radha. She has completed her MS OBGYN. She is an MRC OG from UK and FIMCA and FICOG. She is at present Director and Lead Consultant Fetal Medicine in Resolution Fetal Medicine Center, Hyderabad. She is a chairperson in FOXI Perinatology Committee 2021 to 23. She is a member representative of AIC RCOG in 2021 to 23. She is a treasurer in OGSH 2019 to 21. She is a chairperson in Fetal Medicine Committee of OGSH from 2019 to 2022. She has won Asia GCC Award for Excellence and Leadership in Healthcare.
If you're okay, madam, I think just permit me to start, please.
And I take immense pleasure and welcome you for this session, ma'am.
Thank you so much, Dr. Purnima. At the outset, I really thank Suman madam and Supriya madam for this wonderful opportunity. And it's a lovely meeting and meeting all seniors like P.K. Shah sir, Jaya madam, Sampath Kumari madam, Ramani Devi madam. It's really a pleasure to be here. And I'm speaking on something which is sometimes alarming to obstetricians. When you have twin pregnancies and one of them has an anomaly, it becomes a little bit of a challenge to all of us. So we all know that there is a natural incidence of twins, which we always thought was based on the Helen's law. But knowing that now with all ART procedures and everything, the actual incidence of multiple pregnancies is increasing, and still the majority of multiple pregnancies are twins. And I'm going to stick to twins for today's discussion because they are far more common. And twins can be of two types, dichorionics and monochorionics. So the dichorionics are like two completely different zygotes which are present in the womb at the same time. So the risk of anomaly in these babies is almost similar to that of singletons. Whereas monochorionics, they have a 3 times higher risk of discordant anomaly because there could be an unequal distribution of the cell masses at the time of cleavage or vascular events during the process of formation of the embryo. So all these anomalies like neural tube defects, brain lesions, facial clefts, GI defects can be seen in, and cardiac defects can be seen in 1 or 2 of the babies in a twin pregnancy. If both the babies are affected, the decision is straightforward. You don't go ahead with the pregnancy if it's uncorrectable, or you continue the pregnancy and plan for correction later. The dilemmas arise when one of the baby has a major malformation, and that's what we call a discordant anomaly. So whenever there is a defect in the structure of an organ in any one of the fetus, but it is not that there in the other one, you're dealing with a pregnancy where there are 2 babies, one which is like any other normal baby, the other one which has special requirements. And because of the special requirements, does the plan for the pregnancy change? So whenever you diagnose anomaly in one of the twins of a twin pregnancy, there is a beginning of a complex counseling because you need to explain this to the parents who are not prepared mentally to handle any kind of bad news there. And you're telling them that, look, one of the babies has a heart defect. So it's a very difficult decision making. Sometimes they get worried and they might want to terminate the whole pregnancy. And then you need to sit with them and say that, no, it's not necessary that you terminate the whole pregnancy because there is also a healthy baby there. And what can you do? Either this problem can be corrected after birth, so you continue the pregnancy with expectant care and plan for postnatal correction, or you do a selective termination of the anomalous baby. Now, when to do what will take a lot of analysis of each individual case. And the problem with these kind of situations is the risk of prematurity to both the babies, the risk of growth restriction, even to the normal co-twin, and all these structural anomalies can have impact on the way the pregnancy continues. So what are our major concerns? That the one which has a major anomaly has a very poor prognosis and it may be even lethal. So you may terminate the pregnancy, but then that will be an unnecessary loss of the healthy baby. If you continue, there will be a risk of, need for postnatal care. And if you do selective fetal reduction, a lot of questions have to be answered. But if there is an unexpected fetal death in the baby which is anomalous, again, that may not be a problem if it is a dichorionic pregnancy, but it will be a problem if it is a monochorionic pregnancy. So suppose you have a patient here, which is a twin pregnancy with one normal fetus and one holoprosencephaly, 19 weeks gestation, mother is 26-year-old, gravida 2, para 1, live 1. How would you handle this pregnancy? If I ask you the question, I expect you to immediately ask me, what is the chorionicity? Because in fetal medicine discussions, we don't recognize just twins. Unless we know whether it is monochorionic or dichorionic, we will not be able to make any plan. So chorionicity is very important, and this early pregnancy signs for chorionicity must be documented in any twin pregnancy. So if you see a lambda sign with twin peak or the chorionic tissue in between, it's dichorionic, which means they don't have any vascular connections within themselves. But if there is a T sign like this, then it is a monochorionic, like the one you're seeing in the video. There is a T sign, and that means that they have vascular connections between the two twins through the placenta. So when there is a monochorionic or a dichorionic pregnancy, your decisions will be different. So coming back to the same question, what would you do if there is one baby with holoprosencephaly and the other one being completely normal? So if it is a dichorionic diamniotic twin pregnancy, you may even leave it alone if the Leica is normal, because that complete holoprosencephaly baby may actually not be viable, and it will not pose a lifelong problem to this family, and therefore why to risk a miscarriage by that intervention? So you may argue that you can leave it expectantly because the postnatal survival rate of this baby is very less, but you cannot guarantee that it is not going to survive postnatally. So there will be a complex discussion with the parents, and they may opt for doing selective fetal reduction, understanding that there is a risk of miscarriage, or they may just continue expectantly, agreeing that postnatally we will have a do not resuscitate protocol and try and not affect this pregnancy with an added risk of miscarriage. However, if it is a monochorionic diamniotic twin pregnancy, you would actually be more eager to terminate that or to reduce that anomalous fetus, because there is a risk of intrauterine fetal death as well. In a dichorionic condition, it might be a relief if there is one intrauterine fetal death, because you are now not going to deal with that anomalous fetus anymore. And actually the reduction which you wanted happened spontaneously. But if this happens in a monochorionic pregnancy, just because there is an intrauterine fetal death, there becomes a risk of neurological injury to the alive fetus. So in this case, you cannot take the risk of an unanticipated intrauterine fetal death. You would actually intervene and cause an iatrogenic sudden occlusion of the fetal vascular connections, resulting in a fetal death, but under controlled circumstances, which will not cause neurological injury to the other baby. So whenever you have two fetuses in utero with one abnormal baby, you have two options: continue as such or do a selective fetal reduction. If you continue as such, you have to continue with the risks to twins. If one of the fetuses has polyhydramnios because of the anomaly, say the fetus has anencephaly or the fetus has a large neural tube defect, then the risk of prematurity gets added to the actual problems. If the second fetus is very abnormal, there may be major management dilemmas at birth. We assume that because the fetus is very abnormal, when it is born, it will not be living after that, and therefore we will not have a problem. But suppose it is a complex heart defect, and the baby is born and it still shows signs of life, and it may go on till 4, 5, 6 days in a very, very precarious situation, it's a big moral dilemma to handle these situations. So we have to think about that possibility also before we decide that, oh, it's okay, the postnatal prognosis is bad, it's okay, even if we don't do anything, it should be fine. So that discussion has to be done with parents, because if they are born alive with signs of life, there are problems with abandoning care after birth. What happens if there is a risk of intrauterine fetal death? As I explained, in dichorionic pregnancies, that may be an acceptable challenge, but in monochorionic pregnancies, we cannot take a risk of unanticipated fetal death. So everything depends on the chorionicity. Now, apart from chorionicity, the other factor which determines the outcomes of discordant anomalies is the actual anomaly. So there are some anomalies which are treatable after birth. For example, club feet, cleft lip palate, diaphragmatic hernia or a CPAM, hydronephrosis. So these conditions have fairly good prognosis with postnatal treatment. So here your target will be continue expectantly, provide the supportive care, take the pregnancy as much to term, and then form a multidisciplinary care team and take care of that anomalous fetus after birth, as you would do in any pediatric surgery unit. However, if that condition is, very bad, but it does not cause polyhydramnios, then also you may avoid the reduction, like severe lower urinary tract obstruction, very early onset obstruction of the bladder by the posterior urethral valves, or bilateral renal agenesis. These conditions lead to severe oligohydramnios or anhydramnios. Now, these babies will not actually do well after birth. They will have lung hypoplasia and they will not survive. So you may argue that instead of adding another risk of miscarriage by a reduction procedure, why not we continue and let the babies be dealt with after birth? The problem happens when they don't, they carry on signs of life for a long time, and that is a very big moral dilemma. So to avoid those dilemmas, selective fetal reduction is an option in discordant twins, where we reduce the anomalous fetus for a better perinatal outcome and convert the twin pregnancy into a singleton viable pregnancy. The commonest method of doing this is intrathoracic potassium chloride, where we insert a needle into the heart of the anomalous baby and inject potassium chloride to achieve asystole of that baby. This can be done in dichorionics, but it cannot be done in monochorionics because there is a vascular connection with the other baby, and that precludes the use of any lethal substance like potassium chloride. So suppose you have a situation like this, where you have a dichorionic diamniotic twin pregnancy with one baby completely normal. You see that head there is normal, the other one has an encephalocele. We would choose to do the reduction, because if we did not do the reduction, the encephalocele baby will have polyhydramnios and affect those. So even at a gestation age of like 13, 14 weeks, we have done a intrathoracic potassium chloride insertion. And if you can see, this baby has lost its viability, whereas the other baby continues to show viability in the color Doppler. So how do we select the fetus? Of course, by the scan, you look at the anomalous fetus, and then you see that it is most accessible, find out a route of access, put in your needle there and achieve asystole. As you can see here, the color does not show any picture there. This is a large cloacal anomaly for which this reduction has been done. So when we look at our entire list of reductions that we've done over the last 5 years, so in the last 5 years, out of 337 total procedures that have been done for selective fetal reduction, 35 have been done in cases of discordant anomaly twins. And the common discordant anomalies were hypoplastic left heart, dysplastic kidneys, encephaloceles, prominent nuchal translucency, and anencephaly, bilateral renal agenesis, acrania, absent corpus callosum, open neural tube defect, ventriculomegaly, body wall defect, or trap sequences. Now, like I said, one can argue about bilateral renal agenesis. Where was the need? But once you do a complete discussion with the parents, many of them opt to have the reduction rather than wait for that, unexpected or unanticipated problems in the newborn period. All this works well for dichorionics. What about monochorionics? So monochorionics have a placental vascular anastomosis, and say in this particular case where you have one baby which has big signs of hydrops here, something is grossly abnormal there, you cannot leave it for a spontaneous intrauterine fetal death because it is a monochorionic pregnancy. So here the option is a non-pharmacological reduction of the baby, and this reduction was achieved here by an intrafetal laser photocoagulation of the abnormal fetus. So in intrafetal laser, which has been described since almost a decade now, that you can put in a needle and then pass the laser fiber through that needle, reach the cord insertion point of that fetus, and just generate heat there so that there is a coagulation at the level of the entry of the umbilical cord. This will cause fetal demise, but it will prevent any backflow into the normal baby or any flow from the normal baby into this circulation now, and therefore prevent any neurological injury in that baby. So it is guided by ultrasound. You can see on color Doppler which is the site where you have to guide your needle. And instead of putting a medicine like we do in potassium chloride, in monochorionic twins, we generate heat by the methods of laser. Sometimes we can do an ultrasound guided bipolar cord cautery, where you put a you put a bipolar forceps across the umbilical cord and generate heat there and cut the circulation at that point. The other commonly used procedure is a radio frequency ablation, similar to laser, but instead of the laser fiber, here the heat is generated by the radio frequency needle. So this is the needle that is used in radio frequency ablation. Under ultrasound guidance, the needle is guided to the right place, and once it is put there, you see in the picture here, the tines open up like an umbrella, and they generate a field within which heat is generated by the radio frequency generator, and you achieve up to 100 to 110 degrees centigrade heat there, and that causes photocoagulation of the not photocoagulation, that causes electric coagulation of the cord insertion point. And this can be done even in anterior placentas, and it has a smaller learning curve than laser itself, and it can be used for selective reduction in cases of abnormal monochorionic twin babies. This is a unique complication of monochorionic twins, where one baby is very well formed, but the other baby does not have a heart. It does not have a head. It does not have anything else. It is an amorphous mass like that, which is nothing but a twin reversed arterial perfusion. And while this is not a fetus in itself, but it can cause a lot of trouble because it does not have a heart. And this mass is pumped by the normal baby. So it adds to the hyperdynamic circulatory load of the normal baby. If we don't treat it, if it becomes too big, then it can cause hydropic failure in the normal baby. So this is how a trap sequence is diagnosed, and it requires serial monitoring. Sometimes when it doesn't become too big, we can just continue and do a expectant care, and that can be managed. But suppose it grows very big, and when it grows very big and the mass exceeds the size of the abdominal circumference of the normal baby, a trap, coagulation needs to be done. It can be done by laser. It can be done by radio frequency ablation. We use radio frequency ablation commonly. So this lady had the procedure at 25 weeks when she was at risk of heart failure of the normal baby, and went on till 31 weeks when she had a PPROM, but the baby was delivered and was resuscitated and did well. So these are the methods which help us in salvaging monochorionic twins with anomalous fetuses. Now, this was another case where the patient was referred to us as twin-to-twin transfusion. So there was, we saw that there was polyhydramnios in one side, but what was not very obvious was that there was no oligohydramnios on the other side. So when we looked at this twin fetus pair very carefully, we realized that this is not a case of twin-to-twin transfusion, but a case of selective growth restriction in the babies. And subsequently, when we followed it up for growth restriction, she went and she started continuing in her own local place, but she came back after some time with severe polyhydramnios in one of the sites, in one of the sacs. And then people told her, oh, you missed, it was twin-to-twin transfusion. But you know what? It was not twin-to-twin transfusion. What was actually happening is the sac which had polyhydramnios was developing a congenital pulmonary airway malformation. So it was a CPAM in that baby. So it was a monochorionic pair. There was polyhydramnios in one of the sacs, but it was not a TTTS. Rather, it was a CPAM. If you see here, the lung had a huge mass which was pushing the heart onto one side, and that was causing polyhydramnios. Now, the risk of hydrops was low given the CVR in this particular pregnancy, and we continued managing it expectantly, knowing the protocol for CPAM. And she managed to go on from 28 to 32 to almost 36 weeks, and she was delivered at full term after which, very close to full term, at around 36 weeks, she got delivered. And after that, the baby was admitted. The evaluation was done. The baby with the CPAM had a surgery, and I had the good fortune of getting the details from the pediatric surgeon, and they could do it thoracoscopically. You saw that big mass which was there, but still they could manage to do a thoracoscopy resection of that particular mass, and that baby did very well after birth. So even if it was a monochorionic twin pregnancy, even if it was having severe polyhydramnios, it did not land in trouble. And just by good counseling and a very, very committed couple, the couple were extremely, extremely cooperative, and they managed to have a good outcome. So that is always helpful if you can put your thoughts across to the parents with discordant anomalies and they are comfortable in taking it further. This is one case where there was an anencephaly in a monochorionic monoamniotic twin pregnancy. It's a monochorionic monoamniotic twin pregnancy, and one of them has an anencephaly. So here again, we did a radiofrequency cord ablation there, and this baby went on till 36 weeks, 2 days. The anencephalic fetus came out at the time of that delivery, and the other baby did very well postnatally. So whenever we do these kind of reductions in monochorionic twins, we have done quite a few of them. It is actually very rewarding when babies grow and things do well. But all is not well. In that entire list of ours, in the 33 procedures that we did, we had 6 miscarriages or intrauterine deaths. So there are complications to fetal reductions. There's a risk of loss of entire pregnancy. There is a risk of infection, preterm delivery, and abnormalities in the surviving co-twin. So sometimes one wonders whether we should do it at all. So all these lead to that complex counseling which I talked of in the beginning, that you have to take the couple through all these features before they decide to do some kind of a interventive procedure in a discordant anomaly. So how to counsel people without scaring them? That I am sure all the seniors here will agree with me when I say that medicine is a science of uncertainty and an art of probability. So there is a science and there is an art in your method of communication with the parents. So how to communicate to people without actually scaring them is something which just comes out of practice. But the more we are seeing multiple pregnancies, the more people are learning how to scan, the more we are able to diagnose these anomalies in one of the fetuses in a multiple pregnancy pair. We need to understand how to manage them. So one fact will never change in prenatal counseling, and that remains that you have to balance the odds. Sometimes the odds may be in the favor of continuing the pregnancy, sometimes they may be in terminating the pregnancy, and sometimes they may be in the form of these kind of interventions. So look at every case individually, counsel the patients correctly, and always follow the principle of do no harm. Thank you very much for a patient hearing.
Very nice.
Thank you so much, ma'am, for a wonderful talk and take-home points. Now I request our chairperson, Dr. S. Vijayalakshmi Madam, to kindly give her concluding remarks.
Yeah. First of all, my sincere thanks. Am I audible?
Yes, ma'am.
Yeah.
Yes, ma'am.
My very sincere thanks to the Ranchi Society, Dr. Supriya, and the entire team for giving us this opportunity on behalf of myself. She had to leave urgently, the chairperson, so I am taking over. And Dr. Chinmayi, I've listened to you many times. Always, it's been an awesome lectures that you give, and the amount of expertise and the work that you do, it truly reflects on it. Personal experience, sharing something. It's really, really great. And it was in this 15 or 20 minutes time, you could really put everything together and give us everything in a nutshell. And how to sum it up, that is really, like summing up what Dr. Chinmayi has told is really very difficult. But just a few things like as a general practitioner, as an obstetrician, like she is a fetal medicine specialist, but patients come to us first. So when they ask us, what should we do? So she has really given us a good insight on how to do. And the best thing about what she has said is a good counseling. That is what is essential. So definitely the importance of chorionicity has been very much emphasized by Dr. Chinmayi. So that is very, very important to know whether it is dichorionic, diamniotic. Then we can decide whether we really need to, if we do go for a fetal reduction and all its complications associated with it, or to conserve the fetus. That's a very important point that she highlighted, which we should know. And then when we prove that the chorionicity is monochorionic, and then with being monochorionic MCDA or MCMA, depending on that, and depending on the anomaly, how to go about the counseling. And you have highlighted beautifully about definitely the maternal risk associated with feticides, selective feticides. But the essential risk of having an intrauterine unexpected IUD with a monochorionic twin gestations and the risk that it may pose for a normal fetus, which we may be losing. So we have to balance and counsel in such a way that the patient accepts, isn't it? So management of the anomalous baby, if it is going to be alive, even that is also another thing which we have to counsel them about. And if they have got to decided that they are going in for a selective feticide, you have excellently described, though we are not going to do it personally as obstetricians, and we are going to let you do it for the patients. It really, you have told us, you have put in what you're actually doing, for whom we can put in potassium chloride, for whom you should not put in potassium chloride. Okay, so that is a very important point. So selective feticide with potassium chloride only in a dichorionicity, not for a monochorionic twin. And the beautifully you have described, she has described us about the intrafetal laser therapy, the radio frequency ablation, and the ease of use of radio frequency ablation. We are really, awesome to see you people doing all these kind of fetal reductions. It's really, amazing that obstetrics has really developed so far, and fetal medicine has grown to leaps and bounds, and we are doing so much for our people. Really very great. And I think, and again, at the end, you have summarized and you have beautifully established that counseling is the most important, definitely very, very important, both as a fetal medicine specialist as well as the basic obstetrician who is going to handle the pregnancy and the patient. Definitely we play a very great role, and you have given us a good insight into the subject. Thank you so much, Dr. Chinmayi Ratha, really awesome, and very thanks a lot. And thanks once again for the organizers for giving us the opportunity. Thank you so much.
Thank you, madam. Thank you. Thank you.
Thank you, ma'am. Now moving
and
on.
Best wishes to all the advanced Women's Day wishes to everybody. All 365 days are Women's Day only, like what Dr. Ajay Mane said. And then for all of you candidates who are going to stand for elections, best wishes to all of you.
Thank you, madam.
Thank you. Thank you, ma'am.
Thank you.
Thank you, ma'am. Now moving on to the next session, we have that is on medical document in obstetrics. For this, we have our chairperson, Dr. S. Santhi Rani, madam. Ma'am is a professor in HOD department of GTMCH Theni, and she is the president Theni Obs and Gynae Society and founder treasurer of Theni Obs and Gynae Society, and secretary of Theni Obs and Gynae Society for 6 years from 2012 to 2018, South Zone Coordinator Medical Disorders in Pregnancy Committee, FOXI. And ma'am, okay, now our next chairperson is Dr. Jyoti Sundaram, madam. She is professor, Department of Obs and Gynae, Madurai Medical College, Government Rajaji Hospital, Madurai. She is the senior consultant, Mitra Hospital, Madurai, and president, Madurai Obs and Gynae Society. Our next chairperson, Dr. Selva Priya, madam. She is the director of Spring Fertility Feto Care Fetogene and clinical director, ND JH Gift Fertility and Fetal Medicine Center, secretary, Nagarcoil Obs and Gynae Society. And I request Dr. Selva Priya, madam, to kindly introduce our speaker, Dr. Ajay Mane, sir. And Dr. Jyoti, ma'am, she will just give a brief introduction of the topic. Dr. Selva Priya, ma'am. Ma'am, is she
Madam
there?
is not there now. Shall I introduce?
Yes, yes, ma'am.
Okay. Thank you, Archana, for this nice words. And thank you, Ranji Society, and especially Suman Sinha, madam, for giving me this opportunity to chair this session along with great people like Jyoti ma'am and Selva Priya. And it's my great pleasure to introduce Ajay Mane sir. He doesn't need introduction actually, especially for Tamil Nadu people. And we have a special bonding with the Theni Obstetric Society and Ajay Mane sir. So only I wanted to introduce him. We have done more than 10 to 12 webinars along with sir. I have great respect for him because even smaller societies he used to connect across the country, and we came to know each other because of him only. And to share our thoughts and ideas, and we learn a lot especially regarding this medical legal aspects. Sir is a medical legal consultant for so many years, and he is doing free of cost services to all the practicing physicians. He is the very apt person for this
Yeah,
talk.
Shanti ma'am, thank you
wish
for
you
the
all
great
success in
words.
the upcoming election, and looking forward to work with you in the upcoming days.
Yes,
now I
ma'am.
invite
Thank
you
you.
for your talk with medical document in obstetrics, sir.
Thank you, ma'am. Thank you, madam. Yeah.
A warm good evening to all. Thanks to Dr. Suman, the president, and Dr. Kiran, the secretary of Ranchi Society, and for giving us this opportunity, being a part of this wonderful webinar. Medical records documentation is an important legal and professional requirement for all practicing obstetricians. Of course, incomplete documentation is very common in all over the world. In one study, which is conducted in Basra Hospital, Iraq, OG department was found to be the worst in documenting the clinical examination, assessment, and notes related to patients' state and the details of any improvement or deterioration of their condition. Nowadays, the SOAP note, an acronym for subjective, objective, assessment, and the plan, is the most common method of documentation used by the obstetrician to input notes into patients' medical records. These records should share the information, and it should be universal and systematic and easy to read format. We are waiting to hear Ajay sir and wish you a very grand success in the forthcoming Fox elections. Over to you, sir.
Thank you, Shanti ma'am and Jyoti Sundaram ma'am. Thank you very much. I will start my sharing. Yeah. Usual question, is it seen?
Yes,
and
sir.
am I heard? Okay.
Yes, sir.
To start with, I must convey my gratitude to Dr. P.K. Shah sir, who is my teacher, mentor, Bhishma Pitamaha Foxy. Sir, pranam. Dr. Jayam Kannan madam, pranam. And Dr. Ramdev madam and Sampath Kumari madam, pranam to all these four legends of the Foxy. Then Dr. Suman Sinha ma'am, Dr. Kiran Trivedi ma'am, and Dr. Supriya Jaiswal ma'am. Dr. Vinita Singh ji, Dr. Chitra TV ji, Dr. Purnipa ji, Dr. S. Vijay Lakshmi madam, Dr. Shanti Rani ma'am, Dr. Jyoti Sundaram madam, and Dr. Shalvi Priya. Then Dr. J. Amla Devi ma'am, Dr. B. Kalpana ma'am, Dr. Hemlata ma'am, Dr. Udaya Arun ma'am, Dr. Vanita R ma'am, Dr. Sashirika madam, Dr. Saroja Velu Swami ma'am, Dr. Kavita Barnwal ma'am, and Dr. Apurva Kumar Datta, my younger brother, and Dr. Archana Pathak, and Chitrakala, and Shield Healthcare. Thank you very much. So basically, I'll be skipping some of the slides because we are a bit late. I'll be skipping this medical legal means what and what. So documents related to the doctor. I zoom in Zoom. I have got some problem because my upper part of the slides are hidden. No. Okay, fine. What are the laws related with the doctors? So just 1, 2, 3, 4, 5, 6. See, I'm not going to read this so many laws here. This is the one slide. This is the second slide. And I have not put so many laws. There are 52 laws which are related with the doctor, hospital, and all of us. So it is very difficult. And the Indian penal codes which are related to us. And the most important penal code is 304A. Death by negligence, then 312 to 316 causing miscarriages without consent. Before 1971, we were having the charges of the miscarriages, and we were having punishment before 1971. But after 1971, we are free. 319 to 322 voluntary causing hurt to grievous hurt, and then 340, 342 wrongful confinement. 419 breach of contract, then 499 defamation. Section 202 intentional omission to give information to chupa ke rakha something. Then 269 negligent act likely to spread infection and disease in dangerous to life. In COVID era, it is very famous now. 269, all the things. So what is the remedy? Okay. On lighter note, I have given these 5 slides. Don't take it seriously, but safety first for doctors. How? There are 5 options. No. Option 1, not to become a doctor, which we missed all. Okay, fine. Then option 2, you are a doctor, but don't do practice, do other businesses, which again we have missed the chance. Some of us may be doing something, but we have missed. Option 3, if you want to do practice, select some non-surgical lines, advisory only and something. Okay. Then option 4, even if you have specialized in some surgical lines, we are gynecologists, no, don't do surgery. Medical gynecologist or non-cutting surgeon. But mind here, if a ghost surgeon comes to your hospital and he or she operates, the liability lies with you because you are writing your name, not his name. And though you write his or her name, the vicarious liability lies with you. So you are not spared from the charge of negligence and all the things. And option 5, this is best option for the surgeons, means the gynecologist and surgeon. Do surgery and strictly follow the basic rules, guidelines, and the instructions. And here comes the medical documentation. Otherwise, you may suffer this. It is from Ramoji Film City, Hyderabad. Okay. What is the medical documentation? Basically, it is a data which is related to the patient in all forms, written or electronic, audio, video, email, fax, images, charts, checklists, etc. All forms, all oral also, but we cannot prove the oral. That's why it is to be written. In India, there are only 3 things which needs written consent. One is PCP-NDT, second is MTP, and third one is organ transplant, and fourth one is blood transfusion. But for all consents, we may take it to the oral, but patient may deny, the patient may become hostile, and we are at problem. So that's why we take it as a written informed consent. Okay. Why it is needed? It is communication proof and treatment proof. Basically, what we have done has been written on the paper is only considered as an accountability. It is our part. Then record keeping for all purposes, maybe insurance, maybe Consumer Protection Act, all the things, and a legislative requirement also is there if something goes wrong. And quality improvement for ourselves. We do regular audits and data analysis every 3 months or every 6 months maybe, and improve ourselves in NABH, in Manyata, in all the forms, or on our own also we can keep it in 2 ways. One is written form, one is electronic. Paperless lifespan, it is very easy. How to do concise, accurate, true, clear, legible, chronological, consistent? Okay, who should do it? This is important. Only doctors are not allowed to do the then the staff who is working under the doctor should do it. And who are they? They are nursing staff, basically the nursing staff which are helping you in a procedure. I'll tell you one instance. In my hospital, basically there was a operation of a pediatric surgeon. He has operated, patient shifted, patient then rebound of anesthesia took place, anesthesiologist gone as usual, and the pediatrician and the pediatric surgeon, they resuscitated the baby, put it on the ventilator, but unfortunately next day the baby expired, and the mob of around 200 people was there in the hospital. They did not give the time. They brought the police. That was fortunate for all of us. I was administrator at that time of the hospital. The police took the paper without giving time to complete. At that time, if police does like this, at that time, just write down a single sentence at the last page where you have completed, means not incomplete paper. Okay. At the line, you just write down, this paper is incomplete. Police has not given time to complete. Officially, legally, you have got 36 hours to complete the paper. Police should give you the time. But at that situation, police do not want to give you time. Maybe another interest of everything. But you are having 36 hours. But if they do not give, write a single sentence. Police has not given time to complete the paper. So paper is incomplete. That sentence will help you in the court of law while you are pleading your case, or it will help your advocate to plead. Then in this case, the judge asks why you have written this, the paper is incomplete. So I was also there. So my advocate said, sir, they have not given the time. So the judge said, okay, you have not written this, you have not performed the resuscitation measures and the helping line. So it is negligence of half an hour. Patient was unattended for half an hour, and that's why patient was shifted to NICU on ventilator and died. We said, no, sir. Then we produced the nursing chart which was there in the indoor paper. The nurses, one nurse was doing the charting, one nurse was giving the injections, one nurse was preparing the injections by doctor's orders. So everything that the third one she was writing: injection, soda bicarb, adrenaline, in very minute one, 4.05, 410, 4.07. This is timing only. And 4 to 4:30, she has written at least 15 to 16 notes on the treatment chart by the nurse. And we showed that document to the judge that, sir, see, the nursing staff has written this. Means the nursing staff is not there to do the treatment on their own. They are there to follow the doctor's orders. And the judge accepted that. The nurses has written, means it has been given to the patient, though it is not present in the doctor's notes, as patient's paper is incomplete by the doctor. Doctor did not get the time to complete the paper, and so he squashed the case. So this is the importance of nurses documentation. Okay. Then who can do it? Midwives, the assistant nursing staff. Then the patients, they can write their complaints or anything on the paper and show it to the doctors while coming. Because many times it happens that they have got one complaint at home, and at the time of consultation they forget, and after going home they again remind it. So ask them to write it down on the paper. That is better for us. So what complaints they are having, we can pursue. Then paramedical staff, your counselor and all the things, and other care providers which are present there. When in a chronological records, it should be day 1, morning, afternoon, night. Day 2, morning, afternoon, night. Day 3, morning, afternoon. It should not like that second day morning you have written the notes and again you are writing something on the last day's night notes. Don't do that. Okay. If you want to cut down a note which is written by you, you just have a single line on that, and below that line you write down new things. Don't scratch it or don't overwrite it. It is very difficult to prove something in the court of law if it is scratched or if it is a overwriting. And I'm sorry, but the handwriting must be good. As ma'am said, 82% of the cases are on gynecologists in India, and all of the world it is seen that the gynecologists are worse in paper. Obviously they are overburdened. No, they are overburdened. No branch is busy with the 12 hours with one patient. So labor takes at least 12 hours to monitor, and then afterwards also. Okay. Monitoring documents, audit of documentation policy at regular intervals, review the standards and quality, and review evidentiary compliance. Okay. I'll skip this. Comprehensive complete record, patient-centered collaborative record, ensure quality confidentiality. Okay. Routine documents. What are the routine documents? This is the list. One is OPD paper. Nowadays, we need to maintain a copy of OPD paper with you. Most of the time, 99%, we write down something on the OPD paper, give it to the patient, and patient lose it. Or patient do not bring it while coming for the second time. And thirdly, if something goes wrong, deliberately or intentionally, they do not produce. No, you have not given. No, you have not written on the paper, and the paper I lost. Then how to prove? So have a photocopy or a carbon copy of your OPD paper and keep it with you. This is for your benefit. Second is indoor paper. In indoor paper, you write all the notes. I told you, morning, afternoon, and whatever not. Okay. Any specialty or any super specialty or any additional specialty comes, maybe orthopedic surgeon, maybe a neurologist, maybe an anesthesiologist, maybe physician, he comes, get the notes written by them in their own handwriting, so that it proves that you have taken proper opinion of second specialist. That will again help you. Pediatrician, make him write the notes in the indoor paper. Okay. And all the things I told you about the nursing chart, input, output chart, temperature chart, everything. And while giving the paper to the police, kindly write down the paper number 1, 2, 3, 4, 5, 6, 7, 8, 32. And on last paper, write it down, 32 total papers handed over to so and so. Have a photocopy of that. Give that photocopy. Don't give original paper. Original paper must be kept with you. Okay. Give the photocopy to that police and get a receipt from that I have received 32 papers of indoor paper from Dr. Ajay Mani. Sign. Then designation and name of that police, maybe Havaldar or some whatnot, on the indoor paper received. That receipt must be maintained with you. Okay. Then investigations. You need to give all original investigations to the patient. So have a photocopy of investigations and attach it with you indoor paper. Okay. So because at the time of litigations, the patient won't produce the original investigations. Say for an example, you have got a case of PIH. You have done so many investigations, and patient said, no, doctor has not given the instruction to do the investigation, so we did not. So basically, it becomes a contributory negligence on the part of patient. What is a contributory negligence? It is a negligence done by the patient, and it is good for doctors to prove that patient is negligent. So doctors are saved. So doctors are not negligent in that case. If the contributory negligence is there, you have advised the test, patient has not done the test, it is a contributory negligence. You have advised the tablets and follow-up, patient has not followed, it becomes a contributory negligence. So contributory negligence is to be registered on the paper, and the investigations are one of the major proof that you have done the investigation. So have a photocopy with you and give the original paper to the patient. It is a patient's right if patient asks the original papers of investigations, not the indoor paper. Patient can ask you the complete bunch of paper. It is their right. And 72 hours are there with your hands to give the complete paper. So form a complete photocopy of the papers and give it to the patient. Prior to that, ask the patient to write an application to you. I need such and such indoor paper, complete the paper for my record in the name, and then only give it to the patient only, not to the relative, patient only, and take a receipt from that. Then OPD register. In OPD register, what you write? Name, age, sex, address, and the accompanying person may or may not be there, but the age proof, maybe Aadhaar card and whatnot. And nowadays we are having cameras, and because I may go with the name of Dr. P.K. Shah. Yes, I'm Dr. P.K. Shah. Who knows? I'm not P.K. Shah. I'm Dr. Ajay Mane. So I need to produce one identification proof, a photo proof, because many of the cases we have seen that the patient came with a different name, and in court they said the different name. So that is the problem. Then next is indoor register. In indoor register, you write down all the things, the diagnosis and what is the fate of the patient. What? Discharge, shifted to another hospital, or death, or discharge against medical advice, or what the procedure has been done, or absconded. That can be the possibility. Many times patient absconds if the particularly some ambiguous patient with a history of some irregularities in their family or something, or female girl, female baby born, the absconds. Then delivery, operation theatre, MTP, PCP and data register. It is a mandatory to maintain everything. Delivery register is to be maintained for 21 years. Okay. Operation theatre register is to be maintained for 5 years. Then MTP register is maintained for 5 years. PCP and data register is to be maintained for 2 years. Okay. Right. Then autoclave register. Many times I have seen that the autoclave slip, the green strips, which becomes black after autoclaving, that has been cut in 2 pieces and stuck in 2 dates, say for 21 and say for 23. So no, sir, we have done autoclave at 2 times. Don't do that. Okay, have a proper autoclaving, because this is a major legal document at the time of cases in the court. Okay, so it proves that you have done the autoclaving, your instruments or your all clothings or your dressings, it was a properly autoclaved and free of infections. Likewise, fumigation register, it is very important. Fumigation register should be maintained regularly. How many times you fumigate your operation theatre or your labor room, that has to be mentioned in that. And say for at least 3 times in a year, you must take the swabs from your operation theatre and send it to the lab and have a report of that swab report. And out of 3, 1 must be from government lab. Why? Because they said that the government lab never lies, and you can manage the report of private labs. May it be possible, but have it. And from where you are going to take the swab? One from operation table, second floor, third wall, fourth that boils apparatus, and fifth the drums, and sixth the trolley. Okay, these are the 6 places from where you take the swab and then fumigate. And then K register. Many times I have seen that so many of the people, they don't know the K register. What is the K register? K register is that register which maintains the purchase of the medicine from your hospital and the medicine which you give to the patient, which you don't sell to the patient, which is given to the patient. Say for an example, IV lines, 4 or 5 IV lines, then MTP pills is given also. So that is to be mentioned in K register. What is the proforma of K register? I'll give the K register proforma: name of the patient, serial number, name of the patient, name of the drug. Then it should match basically. Say for example, you have taken 100 kits of MTP and you have given 50 to the patients. 1, 2, 3, 4, 5, we count in the K register. Okay, given to 50. Okay, what is the remaining 50? Show me the stock. The stock is 50. It should match. That is the K register, and it is demanded by the food and drug inspector whenever he comes to your hospital. You do not want the indoor register, do not want the OPD register, you want that K register. So it is to be maintained. Then what is next? It is a stock register. What is a stock register? You need to enter everything in your hospital. 1, 2, 3 for purchased, 5, 3 consumed, or 1 condemned. So what is in working? That is stock register. Condemnation register, how much instruments you have condemned, that is to be entered in the condemnation register. These are the minor registers, but it is to be important. Meeting minutes register, then duty rotation register. We can prove that at the time of certain situation who were there on the roll call or in the hospital. Nursing attendance register, in and out register, attendance register of all employees, all machine routine servicing record. It is very important document. Okay, we must be producing this servicing record and annual maintenance contract in the court. Then and then only court says that your machineries are all maintained and all in working condition. I'll tell you one incidence of this in and out register. There was one incidence in a hospital, and the relatives took one doctor's name in that. This doctor was also present in that operation theater, and the doctor was out of hospital, and he told in the court, but nobody was willing to accept that. No, doctor, you are also there. Just a foul play, nothing. So the doctor, what did he do? He produced the in and out register of the security guard. Security guard, which stays at the gate only of the every hospital, and he notices who is come. Dr. Ajay Mani. 7:30 came, 9:30 gone. Okay, Dr. P.K. Shah sir. Yeah, 7:30 came, 9 p.m. gone. Likewise, and he produced that in and out register, and depending on that, judge accepted. Okay, this security guard, and the rotation is there, no, of security guard. These security guard, they are no way under influence of any doctor. They do maintain the in and out very strictly, and so it shows that at the time of this incident, which took place in the hospital, the doctor was not in the campus. He was out of hospital, and how can he be blamed that he was involved in the operation? So he was relieved. And who was that person? Me, Dr. Ajay Mani. Okay, and this is the incidents took place with me. So in and out register also is a very important. Supreme Court of India has come out with a very important judgment in Samira Kohli versus Manchanda, that the valid consent, it is a consent, is a proof of your I am not going to detail, proof of communication and everything, because nowadays what Foxy has done, they have given a uniform consent book on the www.foxy.org. It is very beautiful book created by Patel sir and Dilip sir from Pune and Nikhil Datar from Mumbai in the last tenure of Alpesh Bhai. Okay, so you get it downloaded and you can use it. They are uniform consent, means one part is of information, second part is of undertaking. They have beautifully mentioned all the plus and minus points. It included almost all. So you are saved from all litigations that you have not told about this complication. We have not informed about this complication. Everything is mentioned here. They have done a tremendous work. They have taken opinion of retired judges. They have taken opinion of high court judges. They have taken opinion of so many of the legislative authorities, and then they created that very beautiful document. You download it. Uniform consents on PC Foxy website. Okay. And thank you to them. They have given us a document. So what is the requirement in PCP entity? Patient registration number with serial number. What is the serial number? We downloaded 23/2022. That serial number is to be put on the printout of the sonography. It is to be put on the referral sheet also, and it is to be attached at one moment and on the declaration form, because at places I have seen that the declaration form is in a register. It is not with the bunch of the papers which is kept. And whenever the inspector or authority come to you, they take 10% of the total random patients. Means if you have done 100 patients in 1 month, they take 10 papers, 10% of the papers randomly. And at that paper only, we don't have signature, we don't have date, we don't have that referral sheet, and we don't have this number. So we are at fault. No, that appropriate authority is not at fault. So please do maintain a proper register. Keep a separate person for this PCP, entity and MT. They are very tedious documentation. So it is not of that I am frightening you, but you maintain it properly if you can, or don't keep the person changing, because every time you need to train the new person. Array, likewise, you have to do 1, 2, 3, 4, 5, 6. And no, ma'am, she has not come today. Shall I do it? Keep a separate person for them. Okay. Consent for USG is very important. Form F. The Maharashtra government and Government of India now they have given a Form F, which is to be filled online. That has got one advantage, that not a single part is kept vacant. If you keep vacant, it don't get submitted or it don't get printed. In 2012 drive, they have harassed like anything on that vacancy. On one word also they have put one case, NA. NA means not applicable. No, what the authority said in court, no sir, it becomes a non-agriculture. See the appropriate authorities. So we cannot predict them. So do it properly. Doctor's declaration, patient's report copy with the film. It is mandatory to have a printout with you. Film on paper, not a proper film. It is very costly affair. So film and patient's report with you. Referral sheet is very mandatory, and fees receipt, it is optional. It is not a compulsory. In MTP, what we need? Patient registration number, again 323/2022. The number which you enter in form 3, that the MTP register, and then onward you need to write down the MTP number. No name is to be mentioned on, even on discharge card, even on prescription form. Everything. If the patient demands you, ki ma'am, please give me certificate, I need it for insurance policy or I need it for leave purpose, then and then only you need to give and ask the application from the patient that I need such and such document with my name, put it on me. Because putting a name on that and writing down gone under MTP is a breach of confidentiality. And for that, you have a 1 year imprisonment. So mind it, keep it proper and hand it over to the patient only, not to the husband. Hand it over to the patient and take a receipt from that. Okay. Then consent for MTP, that is form C. C is mandatory. You can take another consent additionally, but C is mandatory. Okay. Form 1, and that is not form I. It is form 1. And now form E. From 20 to 24 weeks, they have got new form E. Up to 20 weeks, form 1. Okay. And one doctor opinion up to 20 weeks and 2 doctors opinion up to 24 weeks. Patient USG report, not in law, but on safer side, because it tells you about the position of the pregnancy, whether it is inside the uterus, out of the uterus. Okay. Then Aadhaar card, it is a proof. Then referral sheet, fees receipt, and keep it in a sealed envelope. That is a mandatory. Consumer Protection Act, all the things I have told you about, same thing which is mentioned here. Operation theatre documents, that consent in proper pro forma, operative notes by operative surgeons only. Okay. Anesthesia notes by anesthesiologist. There are two consents separate, one for procedure, one for anesthesia. And if you give the transfusion, it is a third consent. Consent must be different for these three purposes. Operative notes, anesthesia notes by anesthesiologist, drug and injection chart by nursing staff. I told you the importance. Instruments and mop count record, shifting notes, post-operative recovery room notes by you and anesthesiologist. It is very much helpful to you. Order on the indoor paper must include date and time, seen by name of the doctor, daily OPO, and all the things. You routinely do it. Okay. Then USG reports. What is important? Write down those things which you could see and interpret. Mention the portion which was not appreciated well or not at all in reports. Which you have not seen must be mentioned that it is not seen. Because if you don't mention that it is not seen, it is considered that you have seen it and it is in a proper condition. Means it is not having any anomaly. Follow-up time and or date for repeat USG if needed. Oh, I'm so sorry. Follow-up time date you needed for revision of USG shall be given on the report itself. And do not copy paste the report of previous patients. Okay. Then check again before giving it to the patient. Once you prepare the report, you read line by line, word by word. Okay. You need to follow all PCP rules and regulations. Keep separate register for non-pregnant patient. Keep one copy of reports with you, that is on, and get your data transferred to safe gadgets, as these gadgets may get corrupt or the virus or whatnot. So it should be kept at two different places to have safeguard. Don't give guarantee certificate. Nobody will give, but this quack has given this. Negligence, I am skipping this negligence. If you don't write down in the proper notes and don't follow the protocols and it is not written on the paper, then it is considered as negligence. If it is a small amount of negligence, it becomes a civil negligence. You need to pay. If it is a big amount of negligence, maybe life-threatening or life has gone, it becomes a criminal negligence. Okay, and you need to pay the compensation as well as can have 2 years imprisonment. Okay. So I'll need protocol deviation, improving safety. Labor room protocols follow. Keep the protocols on the wall. Ask your nursing staff to read daily or maybe Samuhik Vachan on every weekly. Training and drills are must, because newcomer, they run here and there at the time of emergency. No, ma'am, give me the Prostadine. Madam, where is Prostadine? So it's in a freeze. So where is the refrigerator? So this irritates you at that time only. Okay. Or maybe the amount of normal saline is to be taken. They take the amount of Maxel, and the amount of normal saline is replaced by the Maxel. So it creates a havoc. So regular drills, regular updating of protocols, audit and risk management and everything. These are the WHO protocols. Remember, the biggest lie I tell myself, I don't need to write it down. I will remember it. This is the biggest lie. So checklists are very essential and you follow the checklist. Okay, CCTV cameras, they are nowadays accepted. CCTV camera with the audio recording is the best instrument you got in your facility, because if you don't have time to take the written consent, and if you have explained all the things and audio recording, video recording is done, this can be produced in the court of law. I have taken the consent, that video consent, it is accepted. Okay, the patient is not in condition to give consent. The near relative of the patient can give in that condition, in good faith. Okay, keep good relation with the police, local officer, approved authority, local politicians, colleagues, and one agency. Which agency? Maybe helping agency. And I pray to God that nobody should need my help. But if you need, I'm there always, one phone call away. I have a photograph of this slide. I'm always there with you. And take home message. Be attentive at duty, listen carefully what patient says, follow all protocols, write it down properly, because keep friends. And final word, whatever you have written down on paper in the proper manner is only considered as done or performed. If you do not write, it is considered you have not done that. Though you have done many efforts and did not write it, then it is considered as not done. So please write it down. ओके मुझे रिश्तों की लंबी कतारों से मतलब नहीं, कोई दिल से हो मेरा तो एक शख्स ही काफी है. And who is that shakhs? Your colleague. So help your colleagues in bad situation, so that your colleague will help you in your bad situation. Human empowerment in Israel, is in India, and in India, this is India. And my humble request to you to kindly vote from this 21st of March for the post of Vice President, Foxy. With all your blessings, I may go to Foxy. Thank you. Thank you very much. Ranchi Society and Tamil Nadu Societies for giving me the chance. Thank you. Thank you very much.
Thank you, sir.
Sir, such a nice and informative talk.
Yes, sir.
Thank you.
Thank you, sir. Thank you so much, sir. Sir, I have a question with you. A 18-year-old girl, unwed pregnancy, if she is coming to you for an abortion, medical termination of pregnancy, maybe she may need an anesthesia. Whether you have to make it as a medico-legal case or not, because recently
basically 18 years complete.
regarding that.
Okay, 18 years completed or 18 years incomplete? 17 completed, 18 started. What is the age?
Okay, 18 years completed.
If it is a 18-year completed, she is a major. Okay, you don't need consent of the parent, guardian, anybody. She can give the consent. And if she is less than 18 years, pardon?
For anesthesia also, she can give the consent by herself.
Yes. If she is a major, she can give consent. If she is less than 18 years, you need to have consent of the guardian.
Medico-legal case?
No. Above 18 years, no medical legal case. But if she is less than 18 years, you need to inform the police under POCSO Act, Protection of Child from Sexual Offences. Okay, that is the another act which is on our head. So less than 18 years, married or unmarried, you need to inform the police.
Because above 18, even though she is above 18, if she is an unmarried pregnancy, it is a routine for us to make it as a medical legal case. In government sector.
Not needed.
So whether
Absolutely
it is
not.
Also applicable for
No, absolutely not. Absolutely not needed. No. For MTP also, it is not needed to inform the police if she is a major.
Okay.
Now they have given the clause in amendment that failure of contraception is available for unmarried girls also, who is above 18 years. Then how come it is to that you have to inform the police? No, so no need to inform the police if she is above 18 completed years. That's all.
In Tamil Nadu, it is somewhat different, sir. Apart from the routine,
Madam, see, the law is same for whole India. The appropriate authority make it different.
Still, we are facing some problems here in Tamil Nadu.
Because recently there is a controversy, so that only I want to clear. What is the
any unwanted pregnancy, unmarried girls.
If she is above 18 years, you need not inform anybody.
Thank you, sir. That's
thank you. Yeah.
It was a wonderful talk, sir. You have simply insisted the safety first for ourselves. You have enlightened everything about starting from the OPD paper till the receipts, sir. And all machines, service records should be maintained and ANC records should be maintained. It's a very excellent talk, sir. And finally, as you told, we have to be very friendly with our police officers to avoid many legal issues from them. Thank you, sir. Wonderful talk. We enjoyed, sir. Thank you.
Madam, best wishes for Supriya ma'am, Suman madam, and Chitra ma'am. Special wishes to Ajay Mani sir too. All the best, madam. Thank you.
Thank you. And a happy Women's Day to all the wonderful, beautiful ladies in this forum. A happy, wonderful day. Happy Women's Day to you.
Ma'am, has to be wonderful, madam.
Thank you.
Thank you, ma'am, and thank you, sir, for your valuable inputs and my best wishes. Now moving to our Power Pack panel discussion, which is on hypertensive disorders of pregnancy. For this, we have our moderators, Dr. Suman Sinha, madam, who is the President, Ranchi Obs and Gynae Society, East Zone Coordinator, Medical Disorder in Pregnancy Committee, FOXY, and she is also contesting for Clinical Research Committee, FOXY. Best wishes, madam. And our next moderator is Dr. Kiran Trivedi, madam. She is the organizing secretary of Yuva Conference 2022 and currently secretary Ranchi Obs and Gynae Society. And we have our expert, Dr. Supriya Jaiswal, madam, secretary Patna Obs and Gynae Society, East Zone coordinator of Adolescent Health Committee, FOXY. Now, my best wishes to you, ma'am. And now I hand over this platform to Dr. Suman Sinha, madam.
Thank you, Archana. Thank you so much. We heard at length very comprehensive and elaborate deliberations by your very esteemed speakers, we now move on to a very interesting interactive panel on HDP, which is very pertinent and practical also to prevent maternal and fetal mortality and morbidity. And for this, we have a galaxy of knowledgeable and vibrant experts from across Tamil Nadu, Bihar, and Jharkhand. I welcome my co-moderator, Dr. Kiran Trivedi, and the expert, Dr. Supriya. I welcome all the panelists. Can I have their CV, please? So at the very first, I would like to welcome, invite, and introduce Dr. J. Amla Devi. She is, She is a senior consultant, obstetrician and gynecologist at Annai Perinam Hospital, Dindigul, regarding awards and recognition. She is also president of Dindigul Society, and it's so small written for me, it's very difficult. So, Archana, can you read?
Dr. J. Amla Devi, Madam. She is a senior consultant obstetrician and gynecologist, Annai Perinabam Hospital, Dindigul, and she has served in TN Medical Services in 1972 to 2006. And ma'am has received various awards and she had various recognition. Like she has received District Collector Award for 7 consecutive years. And her field of interest is women empowerment and adolescent health. Can we have the next CV, please?
Yeah, this I can do. Yeah. Now I'd like to welcome Dr. B. Kalpana. Dr. B. Kalpana is a gynecologist and infertility consultant at Guru Hospital. And the responsibilities which she has are, she is secretary of MOGS, that is Madurai Obstetric and Gynec Society, founder secretary Madurai chapter of TEPISTAR MC OT. She is national coordinator for Infertility Committee FOXI, very nice. She's also South Zone coordinator for endometriosis. She had been South Zone coordinator for Endometriosis Committee from 2014 to 2016. Organizing secretary of Madurai Silver Jubilee Conference in 2018. She has been course director for postdoctoral fellowship in endogynecology. Member of institutional ethics and principal investigator in clinical trials. The academic profile, like invited guest lecture in many national international conferences, published 15 papers in national international journals, and awards regarding the awards and accolades. She has the recipient of Best Doctor Award awarded by Dr. MGR Medical University, Golden Excellence International Award by European Continental University, Best Medical Service Award from Madurai District Collector. Welcome, Dr. Kalpana. And now we have Dr. K. Hemlatha with us. She was born in Komarpalayam near Erode. Did her schooling in Government High School, Secondary School. Did her MBBS in 1989 to 1995 in Kasturba Medical College, Mangalore. Did her DGO in 1995 to 1997 in Manipal Academy of High Education at Manipal, Karnataka. Did her diabetology course, very nice, through IMA COP, doing her private practice as an obstetrician in her own hospital named RK Hospital, and she is the secretary of Namakkal OBG Society. Next, please. And now I welcome Dr. S. Udaya Aruna. She is associate professor at Thanjavur Medical College, Thanjavur, and the post which she holds are at she is administrative role at KPV Trichy, and has served as academic officer for 2 years, MCI nodal officer at HMIS nodal officer, register of OG department, and regarding awards and accolades. At college level, she has been awarded with Best Doctor Award 2017. At state level also Best Doctor Award 2018. She has been awarded with 2 appreciation certificates, HIV delivery and dengue fever from the District Collector Trichy, Best Performance Award for the COVID work from District Collector Thanjavur. Congratulations, Dr. Utte Aruna, and many papers he has published, 5 in number, and her interest is in the field of obstetric emergency. So this topic is going to be very, she will like this topic very much, and it will be great informative. It will be informative for us also. Now we have Dr. B.H. Banitha Rukmani. She has graduated from Madras Medical College, DGO from Stanley and MS from Theni Medical College. She is Secretary of Theni Obstetric and Gynec Society, has been a speaker and organizing secretary for FOGSI meetings, presented paper in state and national conferences. Her special interest again is high risk obstetrics. So we will have much of inputs from her also. Next, please. Now we have Dr. Sasi Rekha. She is professor in Department of OG, JIPMER, Puducherry. She has done short-term fellowship in obstetric medicine at the Fernandez Foundation. Many publications are credited to her. More than 25, life member of FOGSI, IAG, SOMI, and ISOM. She is working on preeclampsia and on auditing cesarean section using Robson classification systems and few quality improvement projects. Next, please. Now we have Dr. Saroja Veluswamy. She is MD DGO, graduated from Madurai Medical College, underwent post-graduation in Madurai Medical College, conducted several laparoscopic sterilization during government service, and now consultant of Karthik Nursing Home. Her passion is for NDVH. Next, now we have our own Dr. Kavita Barnawal. She is recipient of Padma Bhushan Kamla Bai Hospital Award. She is consultant and laparoscopic surgeon at Samarpan Hospital, Munger. She is currently secretary of Bhagalpur OB-GYN Society. She is invited as faculty in state and national conferences, contributed many chapters in JP books, conducted more than 6,000 laparoscopic ligation in camps, and her area of interest is high risk obstetrics and hysteroscopy. And next one. Now we have our own Dr. Apurva Kumar Datta from Dhanbad, which is from my own Jharkhand. We all know him. He is national coordinator for FOGSI in CME workshop for safe abortion and contraceptive care 2020, coordinator for FOGSI sexual medical committee from Jharkhand and Bihar, and public awareness in charge of the committee. Regional faculty and master trainer for TOT and Saath, executive founder, member of Jharkhand State Chapter of International Spina Bifida Foundation, winner of this year. He was recipient of Dr. Kamini Rao Yuva Orator of 2020, winner of National IMA Community Service Award in 2019 to 2020, winner of FOGSI Young Turk Award 2019, winner of Padma Bhushan Kamla Bai Hospital Award 2019, winner of FOGSI Traveling Fellowship Award 2017, winner of FOGSI Basant Ben Shah Fellowship for Overseas Study 2018, and he is invited as faculty in many national and international conferences, published many years. So we move on to the panel. So let me allow me to share my screen. Is it visual to you all?
Yes, ma'am.
Okay, let me do full screen. Yes. So I begin with the panel. We all know good decisions come from experience, and experience comes from making one bad decision. And this has been coined by Mark Twain. So we gradually learn day by day. The more the patient we are exposed to, the more we learn, and the more we can give care to our patients. So just a minute. Yes. So regarding this hypertension in pregnancy, regarding its definition, as we all know, overall 2.73% pregnant women suffered from hypertensive disorders, and of which 2.16% suffer from preeclampsia, 0.28% from eclampsia, and 0.29% from chronic hypertension later on. after they develop hypertensive disease in pregnancy. So the maternal near miss cases were 8 times more frequent in preeclampsia and increased to up to 60 times in women with eclampsia. So hypertensive disorders pregnancy are the spectrum of disorder ranging from already existing chronic hypertension to complete multi-system disorders like preeclampsia leading to complications, example given eclampsia, HELPS syndrome, pulmonary edema, acute renal failure, stroke, and left ventricular failure. Incidence of preeclampsia, according to National Eclampsia Registry 2013, 10.3% is the incidence of preeclampsia, 1.9% of eclampsia. Out of it, 50% are antepartum and 13% are postpartum. So we have to be very vigilant in the postpartum period also. And maternal mortality in eclampsia is very high. It is almost 4 to 6%. So let us start with the questions. Is Dr. Hemlata here?
Yes, yes.
Yeah. The first question goes to you, madam. How can you classify hypertensive disorders in pregnancy?
Classification of good evening to everybody.
Yeah.
So I'll start with the session. It's getting late. Classification of
Please mute Dr. Saroja. Please mute.
Sorry, sir.
Yeah.
Classification of hypertensive disorders of pregnancy according to our BP levels. So it's a chronic hypertension which is pre-existing in the patient before getting pregnancy itself or up to 20 weeks of pregnancy. It's a BP value is measured as systolic BP is equal to or more than 140 and diastolic BP is equal to or more than 90. It is before 20 weeks and persists for more than 42 days postpartum in absence of gestational trophoblastic neoplasia or multiple pregnancies. The frequency of chronic hypertension in pregnancy is 1 to 5% of total pregnancies. So gestational hypertension, previously we call it like pregnancy-induced hypertension. So now the terminology is changed to gestational hypertension, which is the patient getting her BP of systolic equal to beyond 140 and diastolic BP of equal to or beyond 90. This is beyond 20 weeks of pregnancy and there is no features of preeclampsia and resolves within 42 days of postpartum.
Yes, which is very important.
Hypertension is 6 to 7% of all the pregnancies. And next is preeclampsia, which is more, it occurs BP on high BP more than 20 weeks. And it is described in when the patient's proteinuria is more than 300 milligrams per day or and atypical preeclampsia without proteinuria with renal, hepatic or neurohematological features also comes under preeclampsia. So these patients are 5 to 7% of pregnancies. And preeclampsia with seizures is called preeclampsia. And there's one more terminology like chronic hypertension superimposed with preeclampsia. That is a patient who is having chronic hypertension or pre-existing hypertension having superimposed preeclampsia on the classification of hypertensive disorder of pregnancies.
Thank you. Thank you. So do you have any other classification, Dr. Kavita? Can you suggest some other classification?
Yes, am I audible, ma'am?
Yes, yes, very much, Kavita.
Okay, thank you so much. So I'm in medical hospital because my mother has been operated for fracture femur, but still I can join. Another classification, there are many classifications for hypertensive disorders of pregnancy. And this is another classification where this is non-severe preeclampsia, blood pressure more than 140/90, but less than 160/110 millimeter mercury. And there are no any pre-monitory symptoms. And all the SDA parameters, lab parameters are normal. That is uric acid, serum creatinine, platelet count, proteinuria, these all are absent. And even urinary protein and creatinine ratio is normal. So all the parameters, hematocrit value, all are normal. So this is called non-severe form of hypertensive disorders pregnancy. Another is severe form, where blood pressure is more than 160 by 110 millimeter mercury, with or without premonitory symptoms, and abnormal HDP lab parameters. That is uric acid, which is first to rise. Thereafter, creatinine will increase, albumin and creatinine ratio will be altered. Also, urinary protein creatinine ratio is increased, hematocrit value will be higher, proteinuria will be present, platelet count will be low. So these can be found in severe hypertensive disorders pregnancy. Third group is early onset preeclampsia, where onset of proteinuric hypertension occurs before 34 weeks of pregnancy. And here, maternal and fetal complications are very high because chances of survival. There are many complications which can occur to mother also. So this is most dangerous form of hypertensive disorder pregnancy. And later, another is late onset preeclampsia, where onset of proteinuric hypertension occurs 30th month as well as TB. And there will be proteinuric hypertension along with other features of preeclampsia.
Yes,
So this is a new classification which has been introduced, and we can follow it.
Yes. So, Dr. Kalpana, is she there? Dr. Kalpana? She was in some emergency. She told me. Is Dr. Kalpana here?
No, ma'am. It seems ma'am is not here.
So, Dr. Apurva, can you tell me what is the pathophysiology? Very simple language.
Yeah. First of all, at the outset, I would like to thanks to none other than but motherly figure and a guardian and senior to me, Dr. Suman Sinha ma'am, for giving us the opportunity. Greeting to all of you from the land of Bhagwan Birsa Munda. I am talking from the land, the coal capital of India, of Dhanbad. Now, when I am coming to the pathophysiology, now we all know during when the placental formation, at the stage of the placental formation, there is a two-wave of invasion of the minute arteriole in the myometrium. So it is usually seen in these type of cases, the second wave of the invasion of that myometrial segment is absent. So what happened? Due to this invasion, when this is absent, both the vasoactive substance are circulating in the circulation, and that's why it caused the increase in the blood pressure in the late second trimester, or in the late second trimester and in the early third trimester of the pregnancy. This is the basic pathophysiology of
there is also alteration of this prostacyclin and thromboxane ratio.
Is also altered. Yeah.
Thank you. Thank you.
Actually, it is late first trimester or second trimester, Apurva?
Yeah, ma'am.
Yeah, there is alteration of prostacyclin and thromboxane ratio. So non-prostacyclin increases and thromboxane decreases. But in cases of preeclampsia and hypertensive disorders, the ratio is not altered from
ultimately endothelial dysfunction is there, and the patient, in cases of underlying disease, is endothelial dysfunction also.
Yes. Will you take this question?
So the next question goes to Apurva only. So very good evening to all the panelists. We already get introduction of each other. So we will proceed further with the more questions. What are the premonitory signs of preeclampsia? Question can be answered by Dr. Apurva.
First of all, in these particular question, what I want to emphasize, because I am from a small places, so we know in the recent there is a lot of lab investigations are there, which are actually the predictor of this type of situation. But when we are actually from a very low resources, we don't have round the clock, the pathology is available. So our clinical sense is very important to detect these type of complications. So what is the most important, the clinical sign is the persistent headache first. Secondly, the blurring of vision, difficulty in breathing. There is maybe the vomiting and epigastric pain. Yeah, many times it is due to normally in the pregnancy, but it is the persistent and it can't be explained by any other thing. We may have to think of about these are the alternative signs. or the patient is always complaining of that, yeah, I am feeling very ill, or the hypertension is uncontrolled. So hypertension is uncontrolled. There may be low urine output, and on examination we can say there is a brisk tendon reflexes, altered sensorium, and sudden onset of the massive edema. Or we can, when the follow-up we are seeing there is a sudden increase in the weight gain, more than 4 kilo in a week. So we can say that yes, these are the actually clinical sign of having these are the preliminary sign of the preeclampsia. What the laboratory investigations we can do? We have LDH level, we have the serum creatinine, we have AST by LT ratio, platelet count less than 1 lakh, or the serum uric acid more than 8 milligram, or protein by creatinine ratio is more than either more than equal to 0.3. These are the laboratory investigations, but many a time in a low resources we are unable to do that, and we have to judge on our clinical sense that maybe these are the sign of the preeclampsia. That's all.
Very rightly said, Dr. Apurva. So in small settings, we have to rely on these symptoms, and rightly said by Kanan ma'am that I can't see the fonts on mobile. So these small tips are very important for our day-to-day practices. So now there is no single Apurva, can you tell the prediction of preeclampsia, how we are going to predict the eclampsia, because universal screening is now recommended, but we have to follow certain norms which is developed by our FOXI also.
This
so
question goes to
score
Sashi.
by the question goes to Dr. Sashi Rekha. So what is the gestosis score actually? How to predict the preeclampsia?
Good evening, everyone, and thank you for the opportunity. So the preeclampsia, there are various ways to predict preeclampsia. We can use clinical risk factors, we can use laboratory parameters, we can use Doppler, but we should use at least some form of risk assessment at the first visit. So gestosis is a simple way of assessing the risk for prediction of preeclampsia based on her various risk factors. So the risk factors are categorized into mild, moderate, and severe, and the scores are being given as 1, 2, or 3. A total score of 3 and above is considered as risk of developing preeclampsia, and the woman should be started on a low dose aspirin, a 75 to 100 milligram between 7 to 14 weeks.
That will ask later.
Ideally, okay. So the high risk factors, especially the woman who has thrombophilia, or pre-gestational diabetes, or any SLE, or a chronic hypertension, or conception following ovulation, ART with the donor ovum. So these are the very high risk factors. A single risk factor itself puts a woman at risk of developing preeclampsia. And the advantage of gestosis score is that we don't need a follow-up visit, we don't need any laboratory parameters. Simple clinical bedside assessment, which can be done by all of us at first visit. So it should be done for every woman. If we find there is a risk of developing preeclampsia, we should start them on low dose aspirin.
Thank you.
So very rightly said. So there is an app which is developed by the FOXI members. So every even CSC and PSC can apply, and these symptoms we can verify in the woman, we can examine, and even one symptom, if it is present of severe variety, she is categorized as more high risk of preeclampsia. So next question goes to Dr. Udaya Aruna. What is the FIGO guideline for predicting preeclampsia? Dr. Udaya?
Yes, ma'am. Thank you, ma'am. First of all, I have to thank you, Suman, ma'am. And Francis Society gave me the opportunity. As per the FIGO classification, the FIGO insisting on the universal screening, ma'am. Actually, all pregnant women should be screened at the earlier. It is a one-step procedure. The screening should be done in first trimester as a combined test. What are the tests they have to do means the maternal high risk factors and mean arterial pressure. Actually, both biophysical and biochemical markers. Biophysical mainly mean arterial pressure and uterine artery Doppler pulsatility index. The biochemical this thing is the pregnancy related plasma this thing Papa A plus this thing placental growth like factor, madam. These are the 4 things to be mainly to be done in case of FIGO insisting on it, madam. And actually, can I explain it, madam? Fully?
Yes, yes.
Hello.
Yes, ma'am. Can you hear, ma'am?
Yes, clear.
Yes, ma'am. The
if you
screening
get
is the
the-
combination.
Yeah.
First, I want the screening
So
by a
we can
combination.
also.
Can I go, ma'am?
So you are
The
not
screening by a-
audible clearly.
Yeah, I'm not audible, ma'am.
No, you are.
Now it is audible. Now it is audible.
Okay, ma'am. The screening by a combination of maternal risk factors, uterine artery Doppler, mean arterial pressure, and placental growth factor, and pregnancy-associated plasma protein A, madam. FIGO encourages all countries and member associations to adopt and promote strategy to ensure this. Because when the combined test is done, we can identify 95% of cases. This thing is only false positive rate is only 10%, madam. So early recognition of preterm preeclampsia. The main motto of FIGO to identify preterm preeclampsia, because the preterm preeclampsia is mostly associated with the poor presentation. So we can early starting of aspirin, thereby we can reduce 62% of the occurrence of the preeclampsia in future, ma'am. That is the main thing by FIGO, ma'am.
Thank you. Thank you very much for inputs. Now, next question goes to Dr. Saruja Velu. What are the diagnostic criteria of preeclampsia?
Am I audible? Hello?
Yes, ma'am. Yes, ma'am.
Already it was discussed by the first two speakers, but I have to emphasize that when a normotensive woman, previously normotensive woman, comes after the 60th week of pregnancy with the blood pressure of systolic blood pressure equal to 140 or more than 140, and diastolic blood pressure equal to 90 or more than 90 millimeter of mercury, it should be taken at 4 hours apart to verify that if she is having that reading, even after 2 readings, we can declare that she is having a hypertension, gestational preeclampsia. Then if she comes with the 160 millimeter of systolic mercury of blood pressure systolic and 110 or more, she is in the severe form of preeclampsia. So already they have discussed about the non-severe and severe form of. Another thing is, apart from the blood pressure, if we go for proteinuria, if the 24 hours urine protein is more than 300 milligram and a protein creatine ratio is more than 0.3, it can be declared as having a proteinuria. She is having preeclampsia. And the dipstick method is when the quantitative assay and qualitative thing is not available, we can go for dipstick test also. Because some patient may not like this 24 hours urinary protein because a compulsive procedure, our people are going for dipstick method. Then comes, apart from this proteinuria, if it is absent, we need to bother. We have to go for other biomarkers like thrombocytopenia, that a platelet count will be less than 1 lakh, and renal insufficiency may show the creatine ratio, creatine concentration may be more than 1.1 or double the amount it may be. And then the liver function, impaired liver function, and all the liver enzymes are double the amount of normal level. So we can come to the conclusion by this finding that she is a case of preeclampsia. And this papilledema and cerebral visual symptoms comes only in the case of imminent eclampsia or in severe form of eclampsia.
Yes. So very rightly said, ma'am, that even if the proteinuria is not there, but the organ dysfunction is present, we have to think for preeclampsia. And the BP you already mentioned.
Yes.
Very.
Yes, ma'am. Yes.
Thank you, ma'am. So next question goes to Dr. Vanita.
Very good evening,
Previous
ma'am.
slide.
Thank you for
Previous slide, So what is the correct method usually? Because we all know that blood pressure measurement is a very trivial thing, but actually what is the correct thing we have to keep in mind while measuring the blood pressure? Please
very
elaborate.
good evening to one and all, madam. Thank you for giving me this opportunity. And the blood pressure measurement should be done, the patient in the sitting posture ideally, and the arm level should be supported at the level of heart, and preferably right hand is better. And cuffs, adult cuff size should be less than 22 centimeters if it is a small one, and for normal it is 22 to 32 centimeters, and if it is a large one, it is 33 to 42 centimeters, and it should be measured in both arms. When one BP measurement is increased, you ideally measure it in both arms, and at a difference of 4 hours interval, and ideally you should take 4 sets of systolic and diastolic measurements to calculate the risk, and finally you just find out the mean arterial pressure measurement, and which is calculated by diastolic blood pressure plus systolic by diastolic divided by 3. That will give you the mean arterial pressure, which is ideally instead of systolic or diastolic increase.
There is one more calculation, Dr.
Yes, systolic plus diastolic into 2 divided by 3 is equal to mean arterial pressure.
So what is the normal map?
When it is more than 140 by 90, it is mild.
No, mean arterial pressure is 85 millimeter of
70
mercury.
to 100, madam. Actually,
Actually, it is 70 to 100. Yes.
More than 80 to 100. But even then, they are stressing the point that if it is more than 90, we have to be careful.
Yes.
More than 90, we have to be taken into account.
So what is the recommendation for proteinuria in preeclampsia? The question goes to Dr. Amla Devi, ma'am.
Good evening to all the team, and thank you very much, Dr. Supriya and Suman, for giving me a wonderful opportunity to participate in this webinar. Am I audible?
Yes, madam.
Yes, ma'am.
This proteinuria, according to ACOG 2020 and NICE 2019, that should be 300 milligram at 0.3 gram of protein should be present in the urine, or if it is in the 24 hours urine, it should be more than that. Already Dr. Saroja Velusamy has mentioned about this, and the 24-hour urine collection may be little difficult. So again, this protein to creatinine ratio should be 0.3 or more. Albumin to creatinine ratio of 8 milligram per millimole can also be considered as proteinuria. Then when these quantitative measures are not available, then you can take and you have to decide about the treatment of the patient immediately, that the urine protein dipsticks can be used. But in these cases, it shows a very high value of false positive and false negative. The urine proteinuria is 1+, there is 75% of false positive. So urine analysis is the only available means of assessing proteinuria. Then you can take it, the dipstick, but it should be more than 2 positive. Proteinuria plus be 2 positive.
Yes, madam.
Positive.
So next question goes to Dr. Hemlata, ma'am.
Yes,
so how you will prevent the preeclampsia? What preventive measures, if we predict that certain woman is at risk of preeclampsia, then what are the preventive measures we will take?
In case of prevention of preeclampsia, usually what we do is like give aspirin as early as possible beyond between 11 to 14 weeks. About the 75 milligrams to 150 milligrams. Previously, we used to give 75 milligrams of aspirin. Nowadays, we can give like from 2021, as Dr. Jayamkannan has said, we give 150 milligrams at night. So then it's a low dose aspirin is good for maternal and fetal safety. It acts on the thromboxane A2 level and prevents the platelet aggregation in the arterioles. The safety profile of 150 milligram per day for Indian women has yet to be confirmed, but still we can give nowadays. So it should be started as early than 12 weeks. Aspirin balances the level of thromboxane A and prostacyclin, which will maintain adequate uterine placental flow and improve placentation. Therefore, it is safe to use low dose aspirin as a prophylaxis to prevent PE up to 2 days prior to delivery, or LSES, or till proteinuria does not develop. And then next drug is like calcium, which we can give to 1 to 1.5 milligrams in a low calcium intake group. It is to be started. Like we don't have exact mechanism how calcium works. Still, we have studies that it works. So and then we can have the risk of preeclampsia. We can explain it to the patient, like whether she gets the headache and all those things. Okay, I can skip that. Okay.
No,
So,
no. I'm not telling you.
Okay, maternal.
This is wrongly placed here. I am asking Suman
Yeah,
to
that's what. That's what. Yeah, and then the patient, we can explain to the patient that what are the risks like during the pregnancy she can develop like visual disturbances or a continuous headache. Those things we can explain to the patient and ask her to come to us immediately as soon as she develops the symptoms, like even sudden onset of edema also. So then we can go in for like in case of multi-pregnancy also, we can ask her to come to us for frequent checkups, so we can check the BP level and proteinuria every time she visits to the clinic. So by that way, we can prevent with the medicines and plus certain our examination part also. Then anti-hypertension.
So we have to educate actually our women. Proper counseling should be done, and we should explain properly what are the alert signs. She should inform doctor immediately if these signs are there. So these are the lab parameters wrongly placed here. So next slide, the next.
Now the case discussion.
So now coming to case discussion. Next. The question goes to Dr. Shashi Rekha ma'am. A 28-year-old primary gravida presents at your clinic at 32 weeks of gestation with a single reading of BP, that is 140/96 millimeter of mercury. Then what are the plan? How will you proceed? Will you admit her? What you advise about bed rest? And what investigation will like to do in that patient? Please, ma'am.
Yeah. She is primary and she's 32 weeks with a blood pressure of 140/96 millimeters of mercury. So it's probably early onset.
So it is early onset.
Early onset. So when you see her for the first time in the OPD, we should do a complete history.
Yes.
Yes.
So what will you do?
She is not audible. I think connection is unstable.
Yeah. Am I audible, ma'am?
Yes.
Yeah.
Now tell us, how will you manage?
Look at the review of risk factors for developing preeclampsia. Look at the weight gain and the extent of edema, abdominal edema, ascites, and do a thorough assessment, including respiratory system also, and look for any review of imminent symptoms that she has at present. So that's the first thing we do, and then get a bedside urine protein examination if possible, and send certain laboratory investigations which can help us to increase the certainty of preeclampsia as well as to know whether the woman has severe features or not. So basically, we'll do urine PCR. Second thing is to look at the severe features. We do complete complete hemogram, especially look for platelet count and hematocrit and hemoglobin. Renal function test, especially creatinine, and liver function test, especially bilirubin, AST, and also LDH, and also fundus examination. So uric acid we don't really do nowadays because the only benefit of uric acid is mainly correlated with the perinatal outcome. But we have various other parameters like ultrasound, Doppler to pick up the to identify the perinatal outcome. So we don't really use uric acid. But other laboratory investigations we should do and see whether she has any high risk severe features. If the woman has any respiratory signs, or is she at risk of developing peripartum cardiomyopathy, can get a maternal echo done. And if she has persistent right hypochondriac pain, we can get ultrasound abdomen. Generally, renal Doppler ultrasound kidney is not necessary at the first visit, especially if it's a preeclampsia, unless she has urinary cast or nephrotic range proteinuria or any other clinical pointers suggestive of chronic hypertension. So generally, this is the first thing for maternal evaluation. Second thing is for fetal assessment, we should do ultrasound, biometry, especially look at the placental morphology, Likert, and also Doppler assessment. This gives us a clue whether fetal growth restriction is there, or if it is there, how severe it is. So when we see a patient at the first visit, it's always better to admit the patient for evaluation. The main advantage is we will get a complete clinical picture how the blood pressure is going to be the next 24 to 40.
But recommendation is bed rest should not be recommended routinely for hypertension in pregnancy. But when you see any of the risk factors, any of the premonitory signs and symptoms, then you should.
Yeah,
will you start
yes.
Acha, we'll do in the next. Okay.
Yeah, okay, ma'am.
Thank you.
Yeah.
Thank you for inputs. Actually, bed rest has no increased benefit over the OPD. If the patient is belonging to high risk category, then only we need to admit the patient. So complete workup as discussed by Dr. Sarshi Rekha should be done at the setting, and all the counseling should be done about the alert signs. And next question goes to assuming her blood. Previous slide, Sumande. Assuming her next. Assuming her blood remains investigation remain normal and BP stays below 140/96 millimeter of mercury, then what is the plan of obstetric management actually? And this question is open. Anyone who likes to answer can take this.
In our setup, we'll start with all investigation, admit the patient for complete evaluation, and we'll start an antihypertensive Levitrol, ma'am. In our setup, with the 130/90 itself, we are starting because if we leave without tablet of 130/90, we had so many complications. So we start with antihypertensive.
And 130 or on 140?
140, yeah, 140/96, surely will start, ma'am. Levitrol, the first drug of choice.
But will you deliver this patient? When will you deliver?
What is the obstetric management, ma'am? We will start antihypertensive. But what about the obstetric management? If she is maintaining blood pressure below 140/96 and all the lab parameters are within normal limit, at what time you would like to get her delivery?
Expected delivery complete 27 weeks, unless otherwise warranted. Any imminent symptoms present.
But as Dr. Jayam Kannan has said us, we don't have to prolong the pregnancy more than 37 weeks. So we have to
because
deliver.
Patient doesn't have any imminent signs and symptoms. So only the BP is 140/90. Because this is the first time, we can start on the drug. If it is well controlled, patient doesn't going to develop any other worsening of signs and symptoms, we can wait up to only 37 weeks, not more than that.
Yes, because aspirin
yes, rightly said. So we have to be vigilant about these alert signs, and we have to continuously monitoring by the fetal Doppler and patient's well-being as well as
only one
fetal
more case
well-being.
and then we'll stop. We'll take one more case and then we'll stop because it's almost 9.
So this case is 25-year-old primary gravida, presents at 33 weeks gestation with a BP of 160/100 and trace of protein in urine, that is 1+ by dipstick, and massive pedal edema. Will you start antihypertensive medication? And what will be your choice about the antihypertensive and its dose? So the question is open for everyone. Anyone who can answer it.
Definitely, I will start.
See, it is a case of, I think, severe hypertension, and here proteinuria is also present. So it's the case of preeclampsia. So we have to admit her and watch her regularly, vigilantly. Her ultrasonography should be done with the Doppler velocimetry so that we can assess the fetus. And we have to start the antihypertensive drugs. Systolic blood pressure is very important to see the CNS complications. And we have not to reduce the blood pressure in a short time. We will reduce blood pressure, mean arterial pressure, by 15 to 25% in 60 minutes time. And there are so many drugs which can be used, including labetalol as well as difedipine, hydralazine, whatever suits to her. And if everything is fine, then we can go for termination of the pregnancy. See, 33 weeks now, so we can deliver after waiting for a 1 or 2 days, giving corticosteroid. Even Maxalp should be given, which will not only prevent eclampsia, but also it will increase the neonatal neurovascular
neuroprotection for the neuroprotection.
And we can
Neuroprotection as well.
steroids for lung maturity also.
We'd like to ask about the doses of antihypertensives, because we have to keep on revising it. And
Mostly we are using labetalol, you rightly said. So what is the maximum dose, Kavita Di? How we should start and how should we should increase the dose?
Labetalol starts action in 10 to 15 minutes. So first we have to give 20 milligram slowly and take blood pressure. If it doesn't get controlled, then we will increase the dose by 40 to 60 milligram. Maximum dose that can be given only 300 milligram, or you can give 1 milligram per minute. So you have to adjust the dose accordingly, and we have to watch the patient. So maximum dose that is can be given only 300 milligram. Labetalol.
So once it is controlled, we are going to switch over to oral.
Yeah, oral.
And
We can switch over to oral tablet. Yeah, that is that comes in the name of many drugs. Pregnacid like 100 milligram thrice a day, or
Labate, Lobate, many drugs are available.
Yeah.
So,
Lobate is the best drug, but you can give nifedipine. Suppose.
Yeah, nifedipine can also be given, especially modified
second line
nifedipine.
we are not usually giving, but if it is not controlled by single drug, we can add nifedipine oral.
Yeah.
I wanted to say. If one drug it is not controlled, we can add, instead of increasing the number of doses of the same medicine, we can add on another medicine. Labetalol can be combined with nifedipine.
And you rightly said, Kavita Di, that Maxalp should be given. So how it should be given and what is the dose?
Yes.
So there are so many regimes. Mostly we follow Pritchard regime, that is 4 gram intravenously slowly. Either you can give in 5% dextrose, or with you can dilute in 20 minutes time, and 5 gram IM each buttock. And we have to see whether she is having any toxicity. The Maxalp like respiratory rate, patellar reflexes, urine output, that we have to monitor. And thereafter we can repeat the dose 5 gram 4 to 6 hourly, either till last 24 hours last convulsion or 24 hours after delivery. So we have to.
So what is the therapeutic dose? What is the therapeutic level, serum level?
3 to 7 milligrams. Yeah, 3 to 7. 3 to 7 milligrams. Dose of Maxalp.
And what is the
therapeutic dose is 3 to 7. And after that, 8 milligram patellar reflexes goes. Thereafter, renal function goes down, and thereafter respiratory rates slows down. So we have
to keep watch on urine output.
Normal level is 2
for at least 100 ml in 4 hours.
Yeah, urine output should be 30 ml per hour for 100 ml in 4 hours.
4 hours. So we have to be very vigilant. And what is the antidote? If the solution of magnesium
gluconate can be given if we find either loss of patellar reflexes or urine output low, or if respiratory rate reduced, we can give calcium gluconate in the dose of 20 milligram in 2 minutes time.
This is the kit, I think. This is
it's antidote.
So we can end here, Sumandi.
We can finish.
We will take one more question, or we will end here.
Just we'll take one more question.
Next question. Following delivery, her BP is 8 gram per DL, and platelet count is 50,000. SGOT is 96 and SGPT is 124. So what is our plan? Further plan?
Yeah, she has gone into HELP syndrome, but the good thing is she has already delivered, so our main burden is gone. So if it is only HELP syndrome, probably it will recover in another 3 to 5 days. The platelet count is supposed to improve, but the only thing is she should not go for other severe degrees of thrombotic microangiopathy like thrombotic syndrome or HUS or catastrophic APLA. So thing is, right now she requires only supportive measurement to look for the severity of renal dysfunction or LDH level. If those things are stable, we give only supportive measurement. There's no need to give platelet transfusion. The count is 50,000 and she delivered.
We have to be very vigilant and
not to give blood.
Keep the patient.
Not giving.
Yeah, but anemia can get corrected, madam, because it is 8 grams.
Yes.
Anemia. Hemoglobin is only 8 grams.
And vigilant.
If the patient is stable and hemoglobin is 8 gram per DL, there is no need of blood transfusion according to GCPR. So we can give the injectable iron, that is FCM. That is
Yeah.
best for
Unless
postpartum anemia.
if the ferritin is low, then iron parenteral and otherwise
Yeah,
no need.
yeah.
Probably it will improve.
One thing is very important,
So just we have
multidisciplinary
to be
approach.
very vigilant and keep the patient in close observation.
Yeah,
This is the key.
multidisciplinary
And
approach.
depending upon the condition, we have to take the decision.
Yes.
Otherwise, it should slow over the period of time. She will slowly recover from that syndrome.
And patient should be shifted in HDU. You know, patient has to be shifted in HDU. That is very
Close
important.
monitoring in HDU, madam.
Yeah, because we can get multidisciplinary, help from there. No?
So
Yeah.
I was thinking she was already a case of severe preeclampsia. She is in HDU. So BP of 160, 110. So
All 160, 110, they don't go in HDU. Normally in small setups.
Okay.
So there's one more. We have time, 5 minutes only.
Okay, atypical eclampsia. 20-year-old primary gravida with irregular antenatal checkups. She was admitted at 37 weeks of pregnancy. She was in labor with BP 130 and 80, and the lab parameters were unremarkable. Hemoglobin was 12 gram per DL, platelet 1.2, ALT 31, AST 35, LDS 570, and creatinine was also 0.5 milligram per DL. Proteinuria was stress, but 4 hours after the vaginal delivery of a live baby, she had convulsions. So this type of patient, what is your diagnosis and how you will going to manage the case? The question goes to Saroja Velu, ma'am. Ma'am is here. Dr. Saroja is here. So anyone interested can answer this question.
Unless otherwise food, we have to consider it's a postpartum eclampsia, ma'am. You have to consider.
Oh, it is?
Yeah.
BP is normal, every lab parameter is normal, so it is a case of atypical.
Even with the BP normal, patient can throw fits, madam. It's a categorized under atypical eclampsia. The routine eclampsia management to be followed, madam.
Madam Saroja madam has come in.
Saroja madam is there, ma'am.
Okay, here we need not break our head for getting the diagnosis. Straight away we can give the Maxelf.
Yes.
As a routine dose, loading dose we can give. And later, after you have written that BP is post-seizure is 140/90 and slight decrease in hemoglobin. Before getting all this lab investigation result in our head, we can straight away start the Maxelf dose, because Maxelf we can give any anticonvulsant place, we can give Maxelf. Then only we have to come to a conclusion. Here the readings are BP 130, 140/90 and slight decrease in hemoglobin, of course hemolysis there, then thrombocytopenia is there, elevated liver enzyme, and LDH which is more than 800 suggestive of it is an eclampsia, and 24 hours urinary protein is 330, all suggestive of eclampsia. Then CT and all, we cannot send the patient immediately for CT. How can we send the patient when she throw convulsion immediately? We cannot get the CT diagnosis. So we have to treat them and go for the investigation one by one. It may be a HELLP syndrome also. So we have to do diagnosis of HELLP syndrome and we can treat accordingly. Yes. And we symptom proteinuria plus one more. These are all the findings. I think given the lab report. I think. Hello.
Yeah, there is proteinuria. Yes. There is proteinuria. 330.
So there is hemolysis. There is increased LDH and proteinuria.
We can come to a conclusion that renal impairment, every multi-organ dysfunction is there. So it is a case of HELLP syndrome and a case of eclampsia. This is typically atypical eclampsia, not a typical eclampsia. But at the time of she is an irregular patient. She was an irregular patient. Who knows her blood pressure before? She would have taken an antihypertensive and would have come. So we have to treat them as an eclamptic patient only.
But she had a normal blood pressure.
Yes, madam.
She had a normal blood pressure before delivery. It was only 138.
Blood pressure before delivery, but she was an irregular patient. When she comes, she would have consumed some antihypertensive. When she was, she was not under our care, madam. She was an irregular patient. So what happened? What would have happened? She would have taken some antihypertensive also. So we can come to a conclusion. It is a case of atypical eclampsia even before breaking our head to get the diagnosis, we can straight away start the maxillary regime. We can start an eclampsia regime.
Very nice.
Ma'am, you rightly said that we should start the treatment, but in atypical eclampsia, increase in BP is not necessary, ma'am. But we have to anyhow start the treatment and treat the patient at the line of eclampsia. So very nice discussion, ma'am. I thank
you,
all the
ma'am.
panelists for vibrant and interactive session. So on behalf of Ranchi Obs and Gynae Society,
I would like to
thank
give
all the esteemed
I would-
panelists for participating in this interactive session. And I also want to ask you to vote and support our president, Dr. Suman Sinha, for the post of chairperson, Clinical Research Committee. Please support her.
Thank you.
Thank you,
Dr.
madam.
Suman,
Thank you very much.
One
Thank
minute,
you
I-
for this great opportunity given to us, even the periphery like Dindigul.
No, Dr.
Thank you
Suman,
very
I
much,
would
ma'am.
like to
Suman,
give-
ma'am.
Dr.
Thank you
Suman,
very much.
Bye.
yeah, I would like to give one comment. Like it was wonderful hearing all both the moderators discussing all the cases on HELLP syndrome and all the treatment, all the investigations, doses of antihypertensives. It was wonderful panel, and I could see all the panelists taking so much of interest in giving all the answers. So very well done. And this is my opinion as an expert of this panel. Thank you very much for the opportunity. And so it was a wonderful panel. Congratulations, all the panelists.
Thank you, ma'am, and happy Women's
Thank
Day.
you, thank you, Supriya. Thank you.
Happy
Yes,
Women's
thank you
Day
very
to
much.
all of you.
Happy Umha. Yeah,
Thank you
Apurva,
very
great
much,
set.
madam. Suman madam, Supriya madam,
Sir,
Ajay Mane sir.
Ajay sir, your lecture is like what to say, sir.
Thank you very much.
सुनते रहे. Thank you so much.
Thank you very much. Thank you very much, all the societies who are participating today.
Dr.
And
Dr. Mane is 2 in 1, lawyer and doctor.
Yeah, definitely.
Yes, yes.
And,
Thank you.
and
Only
he's more
helping
like-
to doctors.
Yes,
you just
yes,
call
yes.
him for any damn thing, and he's always this. Okay, yes, I am here. So
And this, sir,
he's
you have made us
just like an-
understand. Yeah, he
सर को रहना ही है, सर को रहना है, हम लोग के कोई भी प्रॉब्लम है, भगवान न करे आए हम लोग
Very
को
strong in
दवाई
medical legal cases. So
but sometimes sir when we listen to you we get frightened so much na, so many
नहीं इसलिए तो मैं no no
Ajay Mane sir.
Ajay sir,
Saroja
I
madam,
just
Saroja madam.
calculated. I just calculated how many registered I have in my nursing home. I just calculated.
Saroja madam was saying something.